Michael Cannon. Welcome to Dad Saves America.
Thanks for having me. It's great to be here.
So we've known each other a pretty long time. In fact, I think the first time we met may have been at an event where I gave a talk that was followed by Ann Coulter.
Oh, my God.
And mine was all flowery and lovey-dovey about emergent order and, birds flying without being directed. And then her speech was a little different in tone.
I forgot. I thought we had met before that. But I guess I just knew of you before that and was excited to meet you when that happened, and very excited that you were there in that room with me to exchange looks. I think knowing and understanding looks, because when she finished her speech, if I recall correctly, the entire a speech that railed against immigrants. Mm-hmm. The entire room gave her a standing ovation except for 4 people. You, me, and the 2 African-American people in the room for some reason. We were the only people who sat there and were like, no.
Yeah, it was a little harsh for my taste. I have shifted probably more right-wing than you since, but still not there. I'm more skeptical of immigration than I used to be, but I'm nowhere near. In this, the bounds have grown on these things quite a bit. And that's a good place to start, because you are a healthcare policy wonk. And it's very hard to get anyone to talk about healthcare in the public domain with anything other than like slogans and nonsense. And so I thought I'd take our conversation to the wonk place for our viewers to understand what American healthcare is. But a good place to start right now, as we sit here at the beginning of 2026, is fraud.
Oh, great. Yeah.
There's a lot of fraud. There's a lot of fraud in the system. The most recent examples of it relating to like health and human services sort of more broadly are the Somali like child care scams that have seemed to have bilked maybe billions of dollars out of the federal government and maybe sent it to terrorists in Somalia. What's going on with fraud in our healthcare system more broadly? And maybe let's just start with the Somali example, the Somali community example in particular, since that's something that has really like lit our public discourse ablaze for obvious reasons, I think.
So what has happened there is that there have been some fraudulent schemes against healthcare programs and other government programs where the federal government gives money to the states dole out that money to people who qualify or seem to qualify. And there have been a lot of cases of fraud where immigrants to the United States from Somalia, some of whom are now citizens, and some of the Somali people involved in this, I think, may have been born here as well, but of Somali descent. Whatever the case, that has garnered a lot of attention because it does seem to be fairly common in that community, and it is, of course, captured so much attention because it is not just a fraud issue; it's also become an immigration issue. Some people have said this is why we need tighter immigration. But to understand what happened in Minnesota, we have to understand what's happening in healthcare more broadly. And fraud there is ubiquitous. And it's ubiquitous because it's a symptom of the biggest problem in the U.S. health sector, which is what we call moral hazard. When people are not bearing the cost of their own decisions, they tend to engage in more costly behaviors. And in the U.S. health sector, consumers have less control over the money involved than in a lot of other advanced nations, most other advanced nations. For example, people like to say that in the United States we have a free market in healthcare. And in a free market, the consumers would control 100% of the money, and the government would control 0% of the money. Now, where would you guess the United States would exist along that spectrum between the government controlling 0% and 100% of the money? I'll give you a hint. Cuba is at 89%.
All right, I'll keep this quick. If you like what you're hearing and want to hear more, don't forget to hit that like button and subscribe to the channel so you won't miss our new content as it comes out every week. And now, back to the conversation.
Okay, so out of every dollar spent on healthcare services in Cuba, 89% are coming from the Cuban regime itself.
Well, the
from
government's controlling it, so it could be money that the government spends itself, or that private money that they're using some sort of government power to direct one way or another on pain of penalty of law.
Gotcha. Okay.
That's 89.
Well, I'm not going to answer because I'm kind of a geek on this stuff. So rather than answer for myself, I'm going to say if you're not geeked out on healthcare and you're walking along as an average American and all you get about healthcare is what people in politics say, then we have a free market healthcare system that's
absolutely
run by greed. And we spend most of our government money on the military. So therefore, I don't know, is it 25% is controlled by the government in America compared to that commie country of Cuba?
So first of all, most government spending is not on the military. Health spending is the largest category of federal spending, larger than Social Security, larger than defense. And it's not 25% that the government controls in the United States. It's 84%, 5 percentage points away from Cuba, which is at 89%. Now, about half of that spending is government spending. So you're already off by a factor of 2. You're lowballing it by 50%. Another third, though, of U.S. health spending is money that we have to let our employers control, or else the government penalizes us. So that's $1 trillion a year. The government penalizes us through the tax code. So what this means is there's about $4 trillion of spending out there that we really can't control. And we can't, because we can't control it, we don't see the savings if we avoid fraud, if we sign up with health plans that avoid fraud. We're giving all this money to the government that doesn't spend that money as carefully as we would if we were able to control it. And so fraud schemes against government health programs are absolutely rampant. They are the estimates, the official estimates are fraud is about 10% of this $1 trillion of spending. But those a lot of experts have said those estimates are comfortingly low. They could be higher, 20, 30, 40%. And some of the fraud is illegal. Some of it is actually legal, and the politicians are involved in it themselves. And it is so ubiquitous that really what was happening in Minnesota with these Somali communities is just run-of-the-mill stuff. And it's not even unique in terms of maybe they're taking some of the proceeds and sending it abroad, because we've found like Armenian crime syndicates that are running Medicare and Medicaid fraud schemes and sending that money abroad. And we don't know what the Great Society is funding around the world. But this has been a problem for decades. So I'm glad that it's getting more attention. I'm not glad exactly of the reason that it's getting more attention, because people are trying to use this as an argument for greater immigration restrictions. But it is definitely a problem. It's definitely something that we need to address. And just saying, oh, well, we're going to take a zero tolerance policy, or, oh, we're going to ramp up fraud prosecutions, that's not enough. We need wholesale fundamental reform of the way we pay for healthcare in this country. And that means we need reform of who controls the money. So the government shouldn't be controlling 84%. Consumers should be controlling all of that money, 100%.
I want to break that down, the latter part, in a lot of detail, piece by piece, because, but I want to stick with fraud and why, and try to understand that better. So, why is it that if Uncle Sam is cutting checks, fraud is easier? Like, what part of that is it? Just because we haven't, like, for example, it's often been touted that Medicare and Medicaid have very low administrative costs. Is that part of it? It's like, well, administrative costs include like enforcement of the law and making sure, like, when I go abroad and my credit card doesn't run because it can tell that I'm doing something unusual. So they had to invest in that. They have to have somebody ready to pick up the phone and answer me when I call and say I'm on vacation, and then be capable of putting it through. That's all administrative costs. Mm-hmm. So is that the primary reason why the government's so bad at not getting ripped off?
So I know that Milton Friedman is a friend of the show, so let me quote Milton Friedman. He liked to say that nobody spends other people's money as carefully as they spend their own. And that means that when the government is spending $1 trillion on healthcare every year, they're just not going to be as careful about avoiding fraud as if it were their money. They're not going to be as careful about it because they don't suffer any losses. And if they try to crack down on fraud, well, every anti-fraud measure is going to create some inconvenience for the doctors or for the patients. And if you are taking those measures into account when you're choosing, say, a credit card company, the example I like to use is you go to the gas pump. Everyone except for residents of New Jersey know that when you go to the gas pump and use your credit card, they'll make you do what?
Put in your zip code.
Put in your zip code. That's an anti-fraud measure. And that's not a really big hassle, but it does trip me up sometimes. I'm like, all right, fine. When it's someone else, when it's my money and I get a better rate on the credit card, then I'll do that. But if it's someone else's money, that's going to annoy me. And so if the federal government tries to make doctors jump through hoops or patients jump through hoops to avoid fraud, they don't see any of the savings. They have no incentives to go along. They lobby against those things. And so the government can't impose those sorts of anti-fraud measures. And what ends up happening is these government health programs turn into what I like to, the analogy I like to use is ATMs. They're basically like an ATM where if you go to the Medicare program, if you go to the Medicaid program, and you just submit a claim or punch in the right numbers and it matches all of their algorithms and whatever, you got a provider code, you got a procedure code, and you got a patient identification number. You put all that in and it all looks legit, out comes money. And there's no one on the other end checking to see if this was really fraudulent or not. On the rare occasions the government does that, they then try to chase you down and get the money. But if you were some high school dropout who got a computer, bought some of these numbers on the dark web and just started raiding Medicare, move that money to an offshore account, they're not going to get that money ever again. Something similar to that was happening in these Somali frauds against non-healthcare programs.
Yeah.
And there's also, I think the biggest example of fraud, and some people dispute the use of that word fraud to describe this, is what states do to get more federal money out of the Medicaid program. The federal government says we'll cover 50% of the cost of your Medicaid program or 90% for the Obamacare expansion. But there are ways that the states can run scams, basically, that make it look like the state is spending money, but they're really not. So they get more money from the federal government than federal law says they should get, given how much they're sacrificing in order to fund their Medicaid programs. And people have estimated that type of fraud, which you can say is legal, but I think it's still fraud, accounts for about $1 out of $6 in the Medicaid program. That's $160 billion per year. So the Somali fraudsters, if they're breaking the law, they should go to jail, but they're kind of amateurs compared to state politicians and how much money they're able to scam off of the federal government.
I mean, I think we started 2025 and the Trump second term with DOGE.
Yeah.
And at the center, and I was excited about DOGE. At least there was an effort. At least it was put front and center to say, let's take a hard look at what's going on and let's bring some fresh eyes into this and people that know how to use a computer. And it doesn't seem like, in retrospect, even by Elon Musk's own sort of look back in the interviews more recently, that it found the billions, hundreds of billions of dollars. That there was talk of, we're going to find $1 trillion. And that wasn't even so crazy sounding when you look at, like, I think the CBO has said something like $500 billion of waste, fraud, and abuse is in the system. So what happened? Like, why didn't DOGE catch any of this? Is it just that they didn't turn their sights on healthcare? Like, how did the single biggest line item in federal spending, which is essentially healthcare insurance schemes, not get DOGE'd? Or maybe we're waiting for that.
Two reasons. One is a separation of powers reason, and the other is sort of a political economy reason. The separation of powers reason is there's only so much that the executive branch can do by executive action. They can't go in and rescind spending that Congress says you have to spend that. We don't have a monarchy. We have a constitutional republic, and the power of the purse resides with Congress. The president doesn't have the power to disregard what Congress says about, or not lawful authority to disregard what Congress says about spending money. Now, the executive does have some authority to reorganize the executive branch and let some people go and that sort of thing. And whenever DOGE did that, I supported that, even if that ended up increasing the size of government in some funny, complex ways. I said, that's fine. Let's do other things to reduce the size of, to reduce the unintended consequences of those layoffs. There was only, and so I defended the reorganization of HHS, which led to a lot of job losses. But even so, there were only they could only go so far under the law. And I even defended when they fired people and then hired them back on, because sometimes you have to just go in hard, and if you made a mistake, fine, correct it. So that's the sort of separation of powers reason. But the political economy reason is this: every dollar, what you have to understand is that every dollar of wasteful healthcare spending or abusive healthcare spending or fraudulent healthcare spending is a dollar of revenue to somebody, and that somebody, by God, has a lobbyist. And the health sector of the economy spends more money lobbying Congress than any other sector of the economy. 6 times what the defense industry spends. Pharma alone spends 3 times what the defense industry spends. And the health sector has spent more than any other sector on lobbying for the past 26 or 27 years at this point. And so anytime you go in and try to say, well, this dollar of spending is wasteful, or this price that Medicare is paying is too high, or whatever, the industry unleashes its team of lobbyists on the executive branch, on Congress, and they enlist as many, say, Medicare enrollees as they can in order to convince those members of Congress that, no, you don't want to reduce this spending. And here's how good they are at capturing these programs. They've even captured the debate over these programs. Remember how the debate over spending cuts. Remember how the One Big Beautiful Bill Act imposed.
I didn't read it.
Imposed draconian cuts on the Medicaid program.
Oh, draconian cuts is like the biggest.
It's like the go-to phrase.
BS buzzword ever. It's like draconian cuts. It's like, but the spending went up from last year.
Exactly.
Yes, but it was going to go up by so much more.
Exactly.
It's draconian.
Exactly. Under that bill, what the Congressional Budget Office found was you implement all these provisions, and there's lots of complexity and predictions, and who knows what really is going to happen. But usually, the CBO has the best guesstimates about these things, and they said that under the provisions of the One Big Beautiful Bill Act, instead of rising at an average annual rate of 4.5% per year, Medicaid spending would instead rise at an average annual rate of 2.7% per year. That's not a cut. That's a slower rate of growth. But the industry is so good at capturing the debate over healthcare, government health spending, they were able to portray that as a cut. And they have all the ideologues on the left who support these programs and don't want to see any reductions in spending in these programs, at least not when Republicans do them. They went along with that and called these draconian cuts. And so you saw how hard it was just to get a slower rate of growth in these programs. It is even harder to eliminate categories of spending or excessive prices in these programs. Now, I should give the Democrats a little bit of credit, because when they passed the Inflation Reduction Act, there are a lot of parts of that bill that I opposed, but it did try to reduce Medicare spending by getting Medicare to pay lower prices for prescription drugs. And those parts of the bill I supported, but that was really hard to do also. The only way they were able to get that through Congress was by having giveaways to green energy companies and so forth, so they could build a coalition to get that across the finish.
What either of those have to do with inflation reduction, of course, is not clear.
Absolutely nothing.
Gosh, there's so many places to go in trying to understand healthcare in this country, but we're going to try to go through as many of them as possible.
Let's do it.
Okay, so there's tons and tons of people in America and interest groups that don't want any friction to getting federal health-related dollars. So if you need to do the most basic verification that you're actually the person that you say you are, outcome lobbyists and interest groups and community organizers and say you're going to kill grandma or you're taking money away from kids if you verified that the human exists and is qualified under the law to actually receive the money.
Right. And that happens in Obamacare. So one thing that when in 2021, Congress creates extra Obamacare subsidies, there are already Obamacare subsidies to help people afford the very expensive coverage that the Affordable Care Act makes available. In 2021, they expanded those subsidies. They reached all the way up the income scale to $600,000 or something like that.
Wait. So people making 600 grand get a subsidy
Well,
under
they could.
Obamacare?
And the way the math works is if the premiums were high enough and you lived in an area where they were high enough and your income and your household looked like this, then yeah, you could. Probably no one north of $500,000 per year got what by people between $200,000 and $500,000 to get subsidy. Anyway.
Great.
So what these extra subsidies did was they created the opportunity for people to get Obamacare plans without paying anything toward the premium. A lot more people could get Obamacare plans without paying anything themselves toward the premium because the subsidy would cover everything. So they created opportunities for fraudsters to steal people's information, invent new people, give people gift cards in exchange for their information so they could either enroll them in a new plan or switch them from an old plan to a new plan, sometimes without their consent. Because every time a broker did this, they'd get a commission from the insurance companies. And so brokers have been making money hand over fist by fraudulently enrolling people in Obamacare. The insurance companies get great big subsidies, so they're not going to stop it when this happens. And what the Government Accountability Office found was, this is one of Congress's watchdog groups, they found that when they just invented some people who don't even exist, and went and applied for Obamacare plans, 96% of the people of the fake applications they filed were accepted, and the insurance companies got subsidies on their behalf. 96%. Just waved them right on through. They said sometimes when people reuse Social Security numbers for this application and that one, they still approve them. Not even the most basic anti-fraud measures. And there are two groups contributing to this situation where they're not policing fraud at all. One are the insurance companies and the brokers, the industry. So what you might call the bootleggers here.
Yep.
The people who profit off of government activity. They don't want these fraud controls. And so they're more than happy to coach the federal government on how not to implement them. But then there's also the Baptists in this Bootleggers and Baptist Coalition. Those are the true believers in Obamacare. They think health insurance is a fundamental human right, and that the government, the mark of a decent society is that the government provides it to everybody, and they don't want anything that's going to get in the way of people enrolling in life-saving health insurance. So they don't want to have serious fraud controls. They don't want to have people reestablish eligibility more than once per year, and when they do, or if they understate their income and therefore get a bigger subsidy than they're entitled to get under federal law, they don't want people to have to pay back the extra. They make it very easy for people to enroll in these programs, whether they're eligible for them or not. And so we get massive, massive amounts of fraud in Obamacare and similar stories in all of these other programs.
One of the other pieces of recent news related to healthcare that brought it into the sort of kind of public conversation-ish is that the recent government lockdown at the end of last year, government shutdown, I should say, although, yeah. Lock down the government, I'm for. But the government shutdown ended up centering around these Obamacare subsidies that were put in place, I think, during COVID.
Yep.
As one of the many things to say, hey, we've prevented you from working or visiting your dying grandmother or going to church, but here's some money. And one of them was heightened Obamacare subsidies, which were supposed to be temporary, but temporary is never temporary in Washington. So what exactly was going on there? And what's the current state of it as we sit here, even if it might change?
Right. So those subsidies, they said they offered them the stated reason that you offered, which is that people were losing their jobs during COVID and health insurance premiums actually weren't increasing, but they wanted to help people who were suffering during COVID, and this was one of the ways the insurance companies were surely on board with it. So was the rest of the health sector. More money for them too. So in 2021, they created these temporary subsidies. In 2023, they reauthorized them for another 2 years. And then they set them to expire at the end of 2025. Now, what that means is that people who, by the way, in 2025, premiums did spike under the Obamacare exchanges. And they're rising another 26% in 2026. So when those subsidies expired at the end of 2025, premiums were going up 26%, and people were losing either some or all of the subsidy that they had been getting that was hiding the cost of the Obamacare premiums from them. And Democrats thought they made them temporary because they figured, gosh, when they go away, the people who are receiving them will help us lobby to keep them, and the insurance companies will help us lobby to keep them. So even though we're calling them temporary, we expect them to be permanent. Except it didn't work out the way that they had planned. The Republicans didn't cave and reauthorize them. Now they may yet. There's going to be a vote in the House on this, and people are trying to come up with a deal to extend those Obamacare subsidies for the wealthy, as I call them. It remains to be seen what's going to happen there. But the thing is, they don't need to extend the subsidies in order to make health insurance more affordable for the vast majority of people on the exchanges. All they need to do is let people buy Obamacare exempt insurance, which President Trump did for 6 years. And that made health insurance more affordable for people. It did it without expanding Obamacare or spending any more government money. It also did so without destabilizing Obamacare. And so that's what Congress should be doing here, rather than considering spending even more money that they don't have.
So I want to make sure I understand what that alternative is. So I am someone who, for whatever reason, opted to get my health insurance through the healthcare.gov Obamacare exchange.
Sure.
So first of all, let's break this down step by step. What does that mean? Like, what is Obamacare today in 2026? Like, when it's like, oh, Obamacare, what is that?
So it's easiest to explain it with reference to other things. So most U.S. residents who have health insurance get it through an employer. That's because the tax code, and that's more than half of the population.
So I'm at my job. As part of my compensation, I'm offered health insurance, which actually
not
is
all
pre-tax.
Not
right?
all workers,
But yeah, so you said half of the country is in that?
A little more than half.
Okay.
And they get it through an employer because the tax code effectively penalizes you if you don't. And so then if people don't have employer-sponsored insurance, like if they're retired or they're low income,
or you're 1099 and you're a freelancer,
you're a small businessman, or you get laid off, whatever the reason, or you're too sick to work anymore, then you lose that connection, and we have all sorts of gaps. Now, the government created these gaps, and the government's been trying to fill these gaps for decades. That's why we have the Medicare program. That's why we have the Medicaid program for retirees and low-income people. And it's also why we have Obamacare, because if you're not a retiree, if you're not a low-income person, you can't get employer-sponsored insurance, and maybe you have an expensive medical condition, then it's very hard for you to find health insurance. So Obamacare is a system where private health insurance companies can sell health insurance on this government website, basically, that we call an exchange.
Yep.
And if they comply with certain government rules, the most notable of which is you can't charge sick people higher premiums than healthy people, then they can sell on these exchanges, and the people who enroll in those plans can get massive government subsidies to buy those, what are actually very expensive plans that the government designs. And if you are one of those people who wouldn't have had health insurance otherwise, your coverage is going to be, you're going to be able to get health insurance. Because insurance companies would not sell you insurance if you had a pre-existing condition prior to Obamacare. So that's good for you. But if you're one of those people who would have had coverage even without Obamacare, maybe you enrolled in coverage while you were healthy and remained healthy, or then you enrolled in coverage while healthy and then got sick, Obamacare increases your premiums. It makes your coverage worse on several dimensions, and it makes your it limits your choice of doctors and your choice of treatments. And there are examples of people not getting the care that they needed because of the supposed protections in Obamacare. So it reminds me a little bit of what Winston Churchill said about how capitalism is the unequal distribution of wealth, but socialism is the equal distribution of poverty.
Yeah, that's about right.
In the name of providing access to healthcare for people with uninsured people with pre-existing conditions, they made coverage for everyone in this market worse. So in order to help that minority of people, the majority has to suffer through worse coverage, and worse on the dimension of cost, and I think worse on the dimension of quality.
It's okay, so half of Americans are getting their insurance through their employer. That's not Obamacare. That's
Obamacare does regulate that. The Patient Protection and Affordable Care Act had provisions that regulates that as well. But when people are talking about Obamacare, they're talking about this 7% of the population, 24 million people that get coverage through these things that we're calling exchanges.
And then that still leaves a lot of people. So are they all in Medicaid and Medicare for getting health insurance? Does that round things out?
You got about 60 million people, 70 million people in Medicare, maybe 70 million in Medicaid as well. And there's overlap between the two because people can enroll in both programs. And then there's about 25 million people who don't have any health insurance at all, the uninsured. You might think of them as part of the Obamacare market because they are sitting out Obamacare because it's too expensive. They don't want it. They're healthy, or maybe they don't value health insurance very much, or they do, but the premiums are just too high.
So if I'm in that group, on average, what do I look like? Like, am I 20-somethings who feel invincible and just are like, I'm not going to spend $700 a month for crappy EPO coverage that doesn't have any doctors in my area, so I'm just going to say screw it? Like, who are these people? What do the demographics of the uninsured in America today look like?
So a lot of them are going to be undocumented residents, undocumented immigrants who aren't eligible for any of the government subsidies that are out there.
So out of 25 million, that's like what? How much do we know?
I'm not really sure.
Okay.
But a significant chunk is going to be that group. Then you're going to have healthy people who either have high incomes, and so they won't be getting any of these Obamacare subsidies because those disappear above 400% of the federal poverty level. So if you're a family of four earning $129,000 a year or more, you're not going to get coverage. But if you're a single person, the income threshold is lower than that, and where the subsidies disappear. And so it could be those folks who are like, I'm healthy, that's expensive, I'm going to wait until I'm sick to buy health insurance. Or people who just don't value health or health insurance the way that most people do. And you add up all of those folks, you get to 20 million people. I think the best way to reach them would be to give people access to Obamacare exempt plans where the premiums could be 60% lower, and then a lot of them might sign up for those plans, and we would reduce the number of uninsured. But Obamacare effectively prohibits those plans, and so we're not able to do that.
Okay. I want to now try as best I can to break down what is currently called healthcare, because we say healthcare, but most of the time we're actually talking about a financial product called insurance,
right,
in this country, right? Oh, I don't have healthcare. It's like, you don't? It's like, no, if I go to the doctor, or you can go to the doctor. So I remember reading about, I believe it was in Oregon, there was a study of, there was a double-blind study, I don't know if it's technically double-blind, but it might technically be double-blind. There were two groups taken from similar-looking people, as I remember it. One group, low income in both cases. You're smiling with the knowledge of this.
Fascinating study. Yeah.
Well, we'll lay out the Oregon study because it's instructive.
So you're right. Health insurance is not healthcare. Healthcare is not health. People conflate these things. They're not the same. And the Oregon study is a fascinating illustration of why this is the case. Okay, so this is a study that happened prior to Obamacare, and it happened by accident. What it did was it compared people who got health insurance to people who didn't. And the way it came about, fascinating. So the state of Oregon had a Medicaid program before Obamacare. Medicaid already existed, and Obamacare expanded Medicaid to some of the very people that the Oregon study examined. These are people, able-bodied adults beneath 100% beneath the federal poverty line. So who are making, $10,000 to $18,000 per year, or maybe even less than $18,000. So not making very much. And the state of Oregon wanted to expand health insurance to all able-bodied adults below the poverty line, but they didn't have enough money for it. So they're like, all right, we only have money to enroll 10,000 of these people. What's an equitable way to decide who's going to get to enroll and who's not going to get Medicaid? They decided the most equitable way to do it was to have a lottery.
Of course.
To have a lottery.
It's always fair to have random luck on things like healthcare.
So
education, getting into a good school. Let's have it be a lottery.
But by God, that means randomization. And that means we can study them. Okay. That is, and the economists said that. They literally said that. They said, wait, stop, you're randomizing, let us study. Because randomization into the insurance group and non-insurance group is the best way to estimate the impact that health insurance has on all sorts of outcomes, on income, on health, on access to medical care and use of medical care and all sorts of other things. And so what they did was these economists descended upon the state of Oregon and they said, we're going to measure all of this stuff. And what they found was that the people who got Medicaid did use more health care than the people who did not get Medicaid because it was free for them now.
So they went to the doctor, they went to the hospital, they got more.
They went to the emergency room.
This was one of the things that was said about Obamacare at the time of its passage is that right now, the uninsured just go to the emergency room. If we make it less expensive, they'll go less.
Well, they said if we make it free to go to the doctor, they won't go to the emergency room.
That was the
But guess what? It was also free to go to the emergency room now, where it wasn't before. So they actually they went more. They used medical care. I think every measure of healthcare utilization showed more utilization, and they got more diagnoses, and they got more prescriptions, and so forth. And these are all these are inputs, okay? And great. When the price falls, people consume more of something. No surprise there.
Econ 101.
What was really a surprise was outputs. So they got more. They got more medical care. They got more diagnoses. They got all these things.
They consumed more healthcare services,
right? But when it came to outputs, objective measures of physical health, like blood pressure readings, blood sugar, cholesterol readings, these sorts of things, there was no discernible difference. There was a change in self-reported mental health outcomes. There was a lower incidence of self-reported depression among the people who got Medicaid, which is great. Okay, we're seeing some benefit here. Interestingly, 2/3 of that improvement occurred between winning the lottery, knowing you're going to get Medicaid, and using any services. So 2/3 of that income or that increase came before they used any medical care, which raises a lot of interesting questions. So we're not sure that it's the medical care that's delivering that improvement. But
peace of mind that now I have coverage accounted for.
Right. I have financial security.
Yeah.
And that's great. That's, we want people to have peace of mind. That's a benefit. We should not ignore that. But the fact that there were no discernible improvements in these objective measures of physical health should have thrown a stop sign in front of all of these claims that health insurance equals healthcare equals health. It should have thrown a stop sign in front of Congress before it enacted this massive expansion of the Medicaid program to these very people that the Oregon study examined. And it should have thrown a stop sign in front of the states before they implemented that, but it largely did not. They should have demanded, and what I advocated from the get-go was, look, we have reason to question the benefits that we're getting from expanding health insurance, even to the lowest of the low-income people in Obamacare. If you're going to expand the Medicaid program, at least do another randomized controlled study, a larger one, because one of the legitimate responses to these observations that I'm making is the Oregon study was underpowered. There weren't enough people in there to detect the improvements in physical health outcomes that may have happened. And that's valid. Oh, I should have also mentioned no change in mortality. I think it was powered enough for those physical health outcomes like blood pressure, HbA1c, and cholesterol, but not for mortality. But to the extent—
Now, what is it? So just for the layman that doesn't understand powered, what are you talking about?
So in order to have any confidence that the results that you're seeing were not the result of random chance, you got to have a lot of people in the study.
So this is why like a vaccine, phase 3 trial in a vaccine with the FDA needs 30,000 people.
Or any drug. Yeah, the trials get progressively bigger. And the reason the FDA generally requires 2 large randomized controlled trials is because they want the trials to be large so they'll have enough statistical power so that they'll know that the outcome they're seeing is not the result of a random fluke. And then they ask for a second one just to confirm, make sure the first trial still wasn't a random fluke. But we've never done anything like that for public policy interventions. We make drug companies go through these crazy, expensive studies to make sure that the drugs work, but we never do the same thing for the government programs to make sure that they work. And that's what I've been advocating ever since Obamacare became law. If you're going to expand Medicaid, do a large randomized controlled trial like they did in Oregon, but bigger. Do it in a large state like California where you'll have the statistical power, and then at least we'll know if that program is saving lives and what it costs to save lives. And if we could save more lives by spending that money someplace else. But I've never gotten a state to go for it. Whether they expanded Medicaid or I'm talking to advocates of Medicaid expansion in states like Kansas or Texas, states that didn't expand Medicaid. They won't go for it. They don't want to measure whether their ideas would actually produce the results they claim.
And one can understand why that's not happening, because if we can't even get like credit card verification at the gas station level of fraud prevention, having something like waiting on the implementation of a welfare benefit to see if it works is not going to.
And the absolute last people who want to have that study is the healthcare industry, because that's not the only randomized controlled trial that has shown that huge differences in health spending have produced zero discernible physical health outcomes.
I believe there's one by, was it the Rand Corporation that did this?
Right. And there's some from other countries as well. And the last thing you want, if you are making tons and tons of money off of government subsidies, is for studies to show that those government subsidies aren't delivering what you say that they're delivering and what the advocates in Congress say they're delivering, because then the voters might say, well, we don't want to spend that money anymore, and your revenues really start to tank. So there's no appetite in Congress, in the states, for this sort of study of what the government subsidies we're talking about are actually producing.
Let's talk about, real quick. Obamacare, the legislation, the Affordable Care Act, had several pieces to it that you've referenced that I remember from the time. One was rules and regulations that I think applied to all health insurance and to different degrees, right?
Right. Yeah.
That was one. Number 2 was the creation of this new Obamacare marketplace thing.
Uh-huh.
And then the 3rd was the expansion of Medicaid to 4 times the poverty line. Is that right? Is that
4 times the poverty line is the private insurance Obamacare part.
Yeah. How did Medicaid expand?
The expansion of Medicaid, it was if you implement the Medicaid expansion, then everyone in your state below 138% of the federal poverty line, for some reason, would be eligible for Medicaid. And that meant that, generally speaking, that because the only people below that income threshold who weren't already eligible were able-bodied adults, then Obamacare's Medicaid expansion expanded Medicaid to able-bodied adults earning up to 138% of the federal poverty line. Basically the same people that Oregon studied.
So what would that make the income today? 138% of the federal poverty line. Like, what's the federal poverty line?
So I've been doing this so long that I've seen it change over so many years that I forget. And it was around $16,000 per year at some point. What I remember, because I looked it up recently, is that for a family of 4, it's $32,000.
Okay.
So But that's not the applicable level for a single adult. And so someone in a family of four at that level would not be eligible for the Medicaid expansion. And it's in the teens, close to 20,000 is what 138% is, last time I checked.
So you have this really strange thing, which is both with regard to Medicaid and I think other health insurance more broadly in multiple studies, including the Rand Corporation study that was a long time ago, but basically studied like people that got very high deductibles versus not. I forget, but it was like, it basically showed a very similar thing to the Oregon study, that having more healthcare services covered and therefore using more healthcare services didn't seem to help anybody's actual health outcomes. So that raises several questions about why that might be. So one would be, we're just not as good at actually addressing the underlying health problems that we go to the doctor for. So we go and consume get all these tests and get all this blood work and get an MRI and a CAT scan and a this and a that. And we're still in a lot of pain, and we still don't know why our back hurts, and we still don't know why I'm losing feeling in my left arm, whatever. Like, that's one piece. I think all of us as humans in America have experienced this thing where you know something's wrong with you. You go to the doctor over and over and over again. It doesn't really get better. So that's one thing. Like, are they just consuming ineffective services? Because they're consuming more services and not having the outcomes.
Right.
Another piece could be that there's something about these incentives that change people's behavior. That, if I'm not insured, I don't want to go to the hospital. That's changing my behavior in some way. Like, I am not taking risks. Maybe I'm not, I don't know, maybe I'm not going on vacations as much, where I might eat worse or get injured doing something that I don't usually do. I don't know. But there's some behavior change that leads me as the uninsured person to end up not getting as sick as if I had been insured. And there's probably other things under the surface of this that could account for why consuming more healthcare services in all these places and all these studies across so much time doesn't seem to make us healthier, or doesn't seem to make the people studied objectively healthier. And feeling better that your finances are better is not health. That's financial well-being. It's not health. Let's set that aside for now. How do you understand what's going on there?
It's a really complex situation, a fascinating one, and I love wrestling with it and talking about it. So let me see if I can answer your question this way. One interesting prospect that you raise is for why spending more money on medicine doesn't improve health is maybe the existence of subsidies encourages people to engage in less healthy behaviors. So then their baseline health is lower and the medicine's just making up for it. And that's a fascinating and certainly plausible dynamic.
One example that
I'm not aware of any evidence on it, though.
Really? So for example, if I can no longer charge differently, if I was like in some hypothetical actual free market and I was going to issue health insurance the way I'd issue, I don't know, car insurance or homeowners insurance or flood insurance or any other insurance that people buy, and you walk in and you're morbidly obese and you're smoking a cigarette, I'm going to charge you more because you're more likely to get sick. You probably already are.
Right.
Versus like a triathlete that comes in and is doing the work to keep himself fit.
Yep. You're
probably not going to die. You're looking like you're going to die. So it's pretty clear the actuaries kind of work that out.
And one form of subsidy that government can deliver to people that might have this incentive is telling insurance companies you can't charge the couch potato more than the marathoner.
Yeah.
Because then you might get more couch potatoes. If that decreases the cost to them of that behavior, because they'll still be able to get health insurance, then more people might engage in that less healthy behavior. But not a lot of, we could see evidence of that around us. I'm not aware of any solid research tying one to the other. However, there's a lot more evidence on some of the other ways that spending more on medicine might not improve health.
Okay.
And I think the way to understand this is, you and I know, and I think everyone intuitively knows what the diminishing marginal utility of stuff is. That means that the first slice of pizza tastes really good. It makes you really happy. The second one, a little less happy than the first. And the 18th slice of pizza does not make you any happier than you were before you ate it. It might even make you a little less happy than you were. That the 18th slice of pizza is not as valuable as the first one because the utility of each additional slice of pizza is smaller than the one before it.
Yeah.
The same thing is true of medicine. You know, medicine on average is beneficial. That first unit of medicine, which is probably vaccines, they're so incredibly beneficial and save so many lives. Is that first unit is incredibly valuable, and the second unit is too. But at a certain point, the curve flattens out and you're not getting the gains that you were before. And that's what happens with pizza. So everyone understands that that's what happens with pizza. It also happens with medicine. Now, with medicine—
Part of that is also, I imagine, that there's the stuff that we understand pretty well, and then you exhaust that, and now you start to get into the maybe it's fibromyalgia or some other, maybe it's autoimmune, and next thing you know, you're just experimenting.
The uncertainty in medicine is vast. Not just the uncertainty that we as patients face, but also the uncertainty that doctors faced about what you need and whether this pill is going to work and so forth. And so there's a little uncertainty about pizza and whether, you know, that next slice of pizza is going to have something that makes you sick, some food poisoning, get some food poisoning or something. Much less uncertainty, but still a little bit. In medicine, it's much greater. And so because medicine is on average beneficial, people will respond to the uncertainty by saying, well, maybe I'll go to the doctor just in case. And when the government is subsidizing you, you go to the doctor just in case more than if the government were not subsidizing you. And there is solid research to show that. And that when a subsidy gets you to go to the doctor more often, you consume more medical services even beyond that. Like the Rand Health Insurance experiment found, when people got subsidies, they went to the doctor more often than people who didn't get the subsidies. But once they went to the doctor more often, they got the same services as everyone else who went to the doctor, regardless of their baseline health and so forth. And so then what ends up happening is they receive more services, and the additional services that they receive end up not improving their health. And the authors of the Rand Health Insurance experiment brought up a very interesting potential, a very plausible reason why. Because the extra medicine that they received, it wasn't that none of it was beneficial. Some of it was. But to the extent that any of it was beneficial, those health benefits were canceled out in the aggregate numbers by harmful medicine that those folks received.
Yeah, and this gets to something really important that we've all actually experienced if we've had to deal with healthcare.
So when you're subsidizing people, whenever you go to the doctor, whenever people go and consume medical care, there's going to be a mix of beneficial medicine, zero value medicine that doesn't leave you any better or worse off, but also harmful stuff. Here we're talking about adverse drug reactions. We're talking about hospital-acquired infections, misdiagnoses. Mm-hmm. Maybe there was nothing wrong with you. It was all in your head, but your doctor diagnosed you with something, and then you subjected you to a lot of treatments, and that on net harmed you. And there is a phenomenon, it's a rare one, but it's a real one, of healthcare fraud that plays into here. There are people in prison right now, doctors in prison right now, who deliberately misdiagnosed people with cancer so that they could pump you full of chemotherapy agents and bill Medicare for that. So medicine is dangerous, okay? It's not all just going to make you better off. And to figure out what the aggregate impact is, we need those kind of randomized controlled studies. And what we found is in each of the studies that I'm aware of is that there is a very large margin where any beneficial stuff that you might be getting is getting canceled out by harmful stuff. And on average, we're not able to see any improvement in aggregate physical health outcomes beyond a certain point. And exactly why we're not sure, but we think that all of these factors are playing a part. And one thing we are sure of is we need more study if we're going to do this, but no one wants to conduct those studies for reasons that I've mentioned.
I come from a family of docs. My dad's a surgeon. His father was in general medicine. His mother actually was essentially an OBGYN, my grandmother, the most feminist, virulently anti-feminist woman in Philadelphia, probably. My grandfather, I just remember him saying this constantly, and my dad says it too. The last place you want to end up is the hospital, period. Like my grandfather had type 2 diabetes, managed to live into his 90s despite losing both his feet as a result of the diabetes, having several bouts of near death with sepsis and all the horrible stuff that happens as you get older and you have health complications and you end up in the hospital. He was very reluctant to want to go to the hospital. He's like, hospitals are places where people get sick, he said, as a doctor at the hospital. For obvious reasons. You're in the hospital, there's a lot of disease around, there's mistakes, all the things we're talking about, all these risks. They're not small. Do you know off the top of your head how much of how many people out of the share of people that go to the hospital end up with like hospital-based like infections? I feel like I saw this number and it was like really high, like the percentage of total illness in America that's actually the result of the hospital was not small.
So there are various estimates of how many hospital patients experience an adverse, medical error, and then how many of those medical errors led to reduce their health, a worse health outcome, harm their health in some way. And if I recall correctly, it's in the low single digits, but that's still a vast number of people throughout the country and across all hospitalizations. And the estimates that get the most attention are estimates that began with the Institute of Medicine, but that other people did follow-on estimates of the number of deaths due to preventable medical errors. So the Institutes of Medicine did a literature review, and they estimated that every year, 50 to 100,000 people die every year from preventable medical errors.
That's what it was. Yeah, that's just an enormous amount of people.
And keep in mind, the largest estimates of the number of people who died because they didn't have health insurance. These are estimates that people were throwing around before Obamacare, using these estimates as a justification for enacting Obamacare, were about 20,000 lives per year. So here we had this problem of 50 to 100,000 preventable deaths, and we largely ignored that in favor of trying to address a problem that we thought a much smaller problem of 20,000 preventable deaths per year. And if you want to know why we focused on this smaller problem, it's because fixing the larger problem would have required changing the behavior of the healthcare industry, and they don't like that. But they like the additional subsidies they would get from providing health insurance to more people, even if the medicine were dangerous. But that 50 to 100,000 estimate isn't the only one. There are other estimates where people said that we lose 250,000 people per year due to preventable medical errors. And Marty McCary, who's currently the commissioner of the Food and Drug Administration.
I had him on the show actually before he got nominated. So.
Did a study of his own where he estimated it was as high as 400,000 people per year we lose to preventable medical errors. So this is a very real, very large problem. No one knows what the actual number is, but it doesn't need to be as large as it is.
It'll never be zero, right? Because there's doctors are humans. Hospitals are run and occupied by humans. There's going to be mistakes that will inescapably happen because we're human. So it's like, I think there's like this perfectibility, there's like this utopia where we can eliminate all that. It's like, no, you are always going to have mistakes happen, and it's not even malpractice. It's just called human error, despite the best efforts of everyone involved and all the best systems and all the best bureaucracy. I think to like recap this part of our conversation, what the listener should make and viewers should probably understand is that health, not just health insurance, which will financially cover you for some of the costs, but the health care you seek for the problem you feel you have won't necessarily work. And in some cases, I think there's many instances in which the interventions can be like a rabbit hole that leaves you quite a bit worse off, with sometimes stacking amounts of medication with not just adverse effects individually, but this problem of now you have all these medicines. I've known people who were on this stack of medicines. They've gone through multiple doctors, and then they got off all of it. And it was like they were better off having none of the medicine than having this giant stack of pills, because it was just this sort of status quo bias. Let's try this. Let's add this. Oh, that has side effects. Let's take this to deal with those side effects. Now this has new side effects. And oh my gosh, I'm gaining weight from these steroids and blah. And next thing you know, you're like a mess. So how do you understand, just at the most basic level, like, what's medicine good for? I know this is sort of like a super simple, almost stupid question, but like, how should I, as somebody who's listening to this conversation and is like, wait, what are you saying? I should never go to the doctor? Like, how do you understand, like, take away, I want to come back to all the system stuff, but take away the systems. And I'm a person that like has some real medical problem. You know, how should I think about what to do next?
Or if you think you might have a medical problem.
Yeah, it's right. Like, currently you go to like your primary care doctor probably. But are there things that in your study of the system that have produced like practical advice for how to just navigate health problems in this country?
I'm not sure I can improve on the advice that my health econ professor offered, which was if you are considering going to the doctor or considering a treatment recommendation, ask yourself, would I pay for this with my own money? If you would, then yeah, you should probably do that. If not, maybe not, because that's where the moral hazard effects. And you can even ask your doctor, if it were you and you had to pay for this out of pocket, would you do it? And if he sort of hems and haws, then maybe that tells you that it's not as essential. But if he's telling you no, this is really, really important, it's a proven treatment, I have a high degree of confidence that this is going to work, then that suggests that it is that's a much better guide to just your own than just your own intuition about how to spend other people's money. So you can also ask another doctor about this, someone who's you get a second opinion. My health econ professor Robin Hanson at George Mason University also said, if your doctor is recommending a treatment, you can ask, is this something they do at a smaller hospital? Because in the larger hospitals, they tend to do more innovative treatments, but often the innovative stuff doesn't work. It's less proven. And if they don't do it in a smaller hospital, that might indicate that it's one of those things that is not doesn't have the proven track record. On the whole, there isn't enough information out there for us to make these decisions, in part because something we mentioned at the beginning, the consumers aren't in control of the money. And so even though we have demand for all of these sorts of questions that would, or answers to and information that would help us separate the wheat from the chaff here and focus on what it is the highly effective stuff that's going to give us the health outcomes we want. We don't get that information because the health sector doesn't respond to our needs and what we demand. It responds to the needs of the people who control the money. That's the government, and the people who control the government, and as we mentioned before, that's the health sector. And so the government doesn't invest in the kinds of studies that would give you and me the information that we need. It doesn't even invest in the kinds of studies that would tell us whether the government interventions are producing the sort of outcomes that people want. Again, because the government's spending other people's money, and it's not going to spend that carefully.
One of the things that that has happened, and I think has accelerated, is doctors off practices. And I think this does depend on the kind of services being offered. Going to like all cash businesses, right, where there's a place, the most famous one that I first saw doing this, and I know now there's quite a bit of this out there across the country, is to the north of us in Oklahoma, this Oklahoma Surgery Center, where unlike most of our experiences of going to a hospital where you get, no one knows what anything costs, and I want to get to why that is, but we go to the doctor, let's just say it's the middle of the night, I've suddenly got some really sharp pain. I'm like, this is not good. This isn't just a muscle cramp. And I go to the ER because I'm feeling like I'm hunched over and I don't know what's going on. I come out of the ER with, what is it? Whatever it is. I don't know. I'll make something up. Maybe I'll get it wrong. Maybe it's like I have my spleen or something. I don't know. But I come out having been addressed. And then I get a bill that says it's not a bill. And then I get an enormous bill. And then I don't pay it because I'm like, oh my God, $30,000. It's like, and I've got insurance. What's happening? Then eventually I get like a smaller bill that still seems crazy large. And then if I actually look at it, I'm like, what's all happening here? Why is the Tylenol $500? And then I get a separate bill for the anesthesia. And then I get a separate bill for this and a separate bill for that. So I want to later break that stuff down, why that's happening. But there's an alternative, and that is these surgery centers and these private cash-only doctors that are delivering care the way normal businesses deliver goods and services, like when I go to a restaurant or I go to the dentist usually. What's going on there, and why does that seem, why is it I can like go to a place like the Oklahoma Surgery Center and I see like a knee replacement is got a price on it, and that price is a lot lower than I would otherwise get if I go to like a typical hospital, even if it's a good one, and blah blah blah. Like, what's going on there?
That is a perfect illustration of the dynamic we described at the beginning of this conversation, which is that when you're not in control of the money, the health system doesn't respond to you. But when it responds to whoever controls the money. But when the Oklahoma Surgery Center is not accepting insurance, it's only accepting cash, that means that all the money that they're getting directly from you. And so they have to meet your needs. And what are your needs when you're trying to decide whether to get a knee replacement or a hip replacement or some other procedure from a surgeon? You want to know, how many times have they done this? You want to know, how long does the procedure take? You want to know what is the price going to be, and will it be all inclusive? Am I going to get surprise bills later? And you want it to be as convenient as possible without any uncertainty like surprise bills offer. And so they have an incentive to give you all of the information you need in a way that you can understand, so that you can make an intelligent decision, because if they don't get your money. And the reason they do that and everyone else does not is because, not everyone else, but they're sort of the paradigmatic example. The reason they do that is because they saw a need out there, they're trying to fill it, and they've achieved great success among the small sliver of the market where patients are paying for surgeries either out of pocket or directly, and then getting reimbursed from their insurance companies, because that does happen. But the money goes direct. The money that the Surgery Center of Oklahoma gets comes directly from the patient. And so they have to do all of these things. Now, why is that not happening with most hospitals? It's not happening with most hospitals because because we're not the ones controlling the money. More than half of the population has a health insurance through an employer. That means that the employer is choosing the plan, and they pay for that with money that they take out of your salary. So they reduce compensation, or they reduce cash compensation in order to buy the health insurance. So it's really the workers' money, but they don't get to control it. And that's not the only effect that the federal tax code has on how people purchase health insurance. It also creates incentives for people to buy more insurance than they would otherwise. A lot more. Because
so I have been on all sides of this as an employee at a big company at Viacom, as a independent contractor with no employees trying to get insurance in the private market, and now for a decade plus now as an employer with employees and actually having different. So I've seen this whole deal. One of the things I've done as an employer is say explicitly, educationally to my team, to my staff, this is pay. Here's how this works. You've got your salary. You've got taxes that come out of your salary that for well, you've got your federal income tax, but then you've got like Social Security, Medicare, Medicaid, FICA, that stuff. Take that and say there's this hidden part which is getting added to your cost, which is the employer side of those. But I'm paying them, but I could pay you that money, but Uncle Sam's taking it from me as your employer. So just understand that's technically compensation that just you're never seeing. And then if you want to, and you probably should, use our health insurance, that's also money I could just give you cash. But because we're in America and we got this crazy system, if you take it from us, instead of going out and buying it separately, it's not taxed. It's pre-tax dollars, right? So so the marginal dollar is whatever your tax rate is for that next dollar you're going to earn. You are saving that on your health insurance if you get it through your employer.
That's right. That's right. So one way to look at it is this. The average family premium available through an employer is about $27,000 per year. $20,000 of that is how much the employer pays. Okay. But all of it is tax-free. So the fact that it's tax-free means that if you wanted to take that $27,000 all as cash, and then go buy insurance on your own, it wouldn't be tax-free. You lose about a third of that, $9,000 to taxes. So there's a huge penalty if you want to take that money and buy your own health insurance. There's a huge penalty on you going out into the market where everybody would be the surgery center of Oklahoma because they'd all have to give you what you need because you're the one controlling the money. And you would have a choice between health plans, not just surgery centers that gave you package prices, but health plans that said, we will never give you a surprise bill. We will only give you very simple bills with package prices. And you don't get to choose, but you don't get to choose that type of health plan because the government penalizes you if you do that. You have to go with what your employer chooses. And when the government says you have to get health insurance through your employer, it also creates an incentive for you to get more insurance than you would have bought on your own. So your insurance company is now covering or paying for more of your medical expenses. So you're less price sensitive when you go out and are shopping for a surgeon in a hospital. You don't care about the package, about the total price so much because the insurance company is paying for more of it. And the price negotiation, because you don't really care about it, is going to happen between the insurance company and your hospital, your healthcare providers. And that then becomes, instead of a transparent system of price competition in the marketplace, it becomes this opaque negotiation between the two of them where the hospital doesn't want to reveal its prices to anyone but the insurance company because that then compromises their negotiating power, their negotiating position with the other insurance companies. So the prices are opaque. They're not transparent. You don't see what they are when you get the explanation of benefits maybe, or not even when you do, because even if there is a price there, you might get additional surprise bills because the hospital has no incentive to make you happy by working with the anesthesiologist to give you a package price because you're not really the one paying. It's the insurance company who's paying. And if the insurance company is okay with the arrangement, why not? And so the hospitals keep making money off the system this way. The insurance companies keep making money off the system this way. In ways that they never could if you were the one controlling that $27,000 and choosing between health plans that eliminated surprise billing and ones that tried to foist surprise billing on you. And yet we blame all of these things on hospital greed and insurance company greed or whatever, or market failure in healthcare, when really this is all a result of government failure and government penalizing you if you want to control your health insurance dollars and make your own health insurance decisions.
So how the problem is in talking to you about this is there's 10 places to go in each instance because it's so intertwined in such an idiotic way, and it seems completely impossible to see our way out of it. To summarize, you have a situation where tax benefits for employer-provided coverage means why not get the low deductible plan, because that's going to be cheaper if I end up going to the doctor than if I get the money. Like if I just kind of pick the cheaper plan that's got a high deductible, yes, I'll technically get more in my paycheck, but I'm kind of getting less than I would get. So I might as well just get the platinum plan where it's only a $1,500 deductible.
Right. So the way it works is every additional dollar of income, of compensation that you get from your employer, you effectively face a choice. You can either get 66 cents of cash because you lose a third of it to taxes, or you can get $1 worth of health insurance. And when the government distorts the prices like that, people go for the $1 worth of health insurance more often, which brings those deductibles down and makes you less price sensitive and subjects more of the pricing to that opaque process between the hospital and the insurance company. And so it's because the government's distorting the prices that you're agreeing to more health insurance than you would if you were the one controlling that money and buying your own health plan.
So I have had the same car insurance company, Amica Insurance, for like 25 years. Is that right? It's like 25 years. When I first got a car in New Jersey, after like when I could get a car, I got Amica Insurance. I had it for like renter's insurance and stuff. I've been with Amica for a long time. I've never been in a car wreck, but my son's been in several. It was actually, like, all things considered, a pretty transparent and almost pleasant experience. It was like, okay, well, here's what happened. They cut a check for the loss of the car. I mean, not that pleasant because it's like, well, now I don't have a car, so that's not great. But I moved from New Jersey to Texas. I kept Amica Insurance. But when I moved from New Jersey to Texas, I didn't get to keep the health insurance. Like, that was not a thing. But we're in the same country. So I remember at the time of Obamacare, when we actually were having a healthcare reform debate in America, which we have not had since, really. Except maybe you could say, like, whenever it was, 2018 or 17, when Trump said, I'm going to repeal Obamacare, and nothing happened. There was talk of eliminating the lines between states. So what is that? Why is that? So what is this? What is that? Because it's like, I can get Blue Cross Blue Shield, but it's like not. It's Blue Cross Blue Shield of Texas. And there's all these differences between the states. And what are we doing here? We're one country. Like, we move around all the time, but we don't have that in our health insurance. So what's going on?
So with regard to your car insurance, I'm not sure exactly what happened. There's a chance that you got to keep your original New Jersey policy when you moved to Texas.
It was probably new. We changed cars and stuff.
What I expect, though, happened is the same insurance company sold you a Texas policy that they had to run by the Texas regulators. That's more common. And that's certainly the case with health insurance. If you live in Texas, you cannot buy a health insurance plan that's available in any other state unless they put it before the Texas regulators and it complies with all of Texas's regulations. And they vary. No two states have the same insurance regulations. So in effect, what that means is if you live in the state of Texas, the only stuff you can buy is here. Even if you like a plan in New Jersey better, or Idaho, or the U.S. Virgin Islands, you can't buy one of those plans unless they submit it here and it complies with all of Texas's regulations. What that means is Texas has effectively created for itself a monopoly in the provision of consumer protections that we call regulation And no one's allowed to compete with them to provide better consumer protections than Texas does. So even if you like the balance between affordability and protection that the U.S. Virgin Islands strikes better than the one that Texas strikes, forget it, you're out of luck. So before Obamacare, we've been arguing for decades. Free market advocates have been saying, look, monopolies, when it comes to regulation, produce the same thing that monopolies everywhere produce, a high-cost, low-quality product. Why don't we have competition between the regulators? We can let them compete to find the right balance between too much regulation and too little, like we do in corporate chartering or credit cards. Corporate charter corporations can choose where they domicile. A lot of them choose Delaware because they like the regulatory environment. I understand that some of them are now moving to Texas because they like Texas better. Credit card companies like the regulatory environment in South Dakota, and apparently their consumers do too because they sign up for those credit cards, and maybe not everyone is happy, but it's a good equilibrium. We should be doing the same thing with health insurance, free market advocates say, but that we've been saying that since before Obamacare, when there's lots of variation across states. But when Obamacare came onto the scene, it laid a thick, warm blanket of uniform federal regulation over all of the states. And so now, whereas before you might have been able to save some money by buying a plan from Idaho, you're just not going to now because the regulations are the same. However, I've got good news for you, John. I think good news comes from our friend, former President Barack Obama, because in 2014, he exempted U.S. territories from Obamacare's most expensive regulations, which means that if the state of Texas just recognizes plans from the U.S. Virgin Islands as legal in Texas, then you could purchase health insurance that's exempt from Obamacare. Their premiums could be 60% lower. The networks could be wider. Unlike Obamacare plans, they might actually cover MD Anderson, because not a single Obamacare plan has MD Anderson in the network. Premiums lower, broader networks, maybe even lower deductibles, and long-term coverage with renewal guarantees, so you can keep your plan year after year after year. If you get sick, your premiums don't go up. You still pay healthy person premiums. All Texas has to do is say, we recognize those plans. And for good measure, let people enforce any contractual disputes or regulatory disputes here in Texas. And then you provide relief to the people who are seeing their Obamacare premiums go up by 26% and their subsidies disappearing. And it doesn't have to disrupt Obamacare, because President Trump did something very similar for 6 years from 2018 to 2024, and it didn't disrupt Obamacare. Obamacare premiums were fine. They were flat during that period, and Obamacare enrollment even increased. So you can provide, with that intuition that you had, we could provide health insurance much more affordably, better health insurance, more affordably to a lot of people without either expanding or disrupting Obamacare.
What to take a step back to like a common thing that gets said, and I think there's some real truth in it, and there's some stuff that's just fundamentally misunderstood. We are often told, and I don't think it's wrong, that the United States, as a share of all incomes earned, or GDP, which end up being roughly the same thing, we spend more on health care / insurance than any other first world country, and that our outcomes aren't in line with that increase in spending relative to, let's actually pick what I think is probably not the worst of the government systems, like France. Like the UK is just a disaster. Canada sucks. But I think France is actually not the worst. So what's going on there? Is that true? Are we spending a lot more on healthcare and health insurance than the French? Are we getting more for our money or not? Why?
So everything you're saying is correct. Health spending in the United States is higher than in any other country on any measure. Raw dollars, we spend $6 trillion per year. I think it's going to be in 2026. In terms of per capita spending, twice as much as the OECD average. As a share of GDP, 16-17% of GDP on healthcare versus the next year's countries, Germany, at about 12% of GDP. Okay, so we spend vastly more than any other country. but we don't get the measurably better health outcomes. Actually, this is very consistent with what we were discussing in the Oregon study and the Rand health insurance experiment.
Right.
We're spending a lot more. We're not getting better health outcomes. That suggests maybe we should spend less.
Yeah, our marginal consumption of healthcare services is producing
Yes. And I mean, it's a complex story, and that's part of the story. And what do most people do with that information? They add to that those data the presumption that, well, the United States has a free market in healthcare, and so this is what free markets produce: wild spending, excessive prices, and poor health outcomes. But remember what we discussed at the beginning when I said that in the United States, government controls 84% of the health spending. That's actually more than the OECD average. The OECD average is 76%. And that's more than in the UK, which is about 82, and it's more than Canada, which is 71%. So that casts those data in a whole new light, because the United States is different from the average OECD nation, not because we have freer markets, but because we have less free markets. And if you were ready to conclude when you thought that free markets were contributing to this wildly wasteful system that we have, where we're spending more than anyone else and not getting commensurately better health, shouldn't you also then be at least questioning, well, wait a second, maybe it's excessive government involvement in the U.S. health sector, more than in other countries, that is leading us to spend so much more and not get commensurately better health outcomes. And there's a lot of evidence. You should be asking that because there's a lot of evidence to support that conclusion. The Medicare program in the United States, remember, Bernie Sanders wants us all to be in Medicare. Healthcare will be much more efficient, more in line with other countries. Medicare is less in line with other countries than the rest of the U.S. health sector when it comes to spending. When you compare us to the seven wealthiest nations, on average, we spend twice as much as they do per person. But among the elderly, well, it's actually 90% more than they do. A
little less than double.
Yeah, but among the elderly, it's twice as much, so 100% more. So we're even more, Medicare is even more out of line with international norms than the rest of the U.S. health sector.
Is that just because they've got death camps or death panels or whatever was the thing that was...
Death panels would reduce Medicare spending.
Right.
But we don't...
But do they have them?
No, we don't.
And, Canada's paying people to kill themselves, right? So is that saving them money? I'm not saying we should do that, by the way.
For the record, what everyone calls death panels is really just a government agency, or you can have private death panels, but some sort of agency that's trying to decide whether spending the marginal dollar on this medical intervention would produce more health than spending it on that medical intervention. If not, we should spend it on the other one. So these are not death panels that we're talking about. These are life panels because they're trying to get us as much health as possible per dollar spent. So, but no, we don't have them in Medicare. We just spend in Medicare. And that is why, that is one of the main drivers of excessive health spending in the United States. The best research that we have shows, and this is again consistent with the Oregon and the Rand health insurance experiments, that in the Medicare program, 1 out of every $3 that Medicare spends does exactly nothing to improve, to benefit patients. It doesn't make them any healthier. It doesn't make them any happier with the care that they're receiving. It is just, that 10th visit to the cardiologist that does nothing to health outcomes, or that totally unnecessary hospitalization or what have you. And so there's tons and tons of waste in the Medicare program, and we can't get rid of it. Why? Because it's revenue. It's somebody, and that somebody has a lobbyist.
How much of that 90 to 100% in additional spending do we do per capita is because we're just fat as a country. We're just fat people. You go abroad. I know I'm being impolite, but come on, it's 2026.
How much of the additional spending is due to
our lifestyle,
to poor lifestyle, or how much of the additional subsidies encourage unhealthy lifestyles? It's really hard to know. Certainly, we do seem to have more of a problem with
chronic disease related to
and obesity. In the United States and in some other countries, it's unclear how much of that, or there are estimates, they're escaping me now, of how much spending is due to the chronic diseases generally and those related to obesity in particular. But and it's even less clear how much the government subsidies for healthcare are encouraging people to engage in those unhealthy behaviors that contribute to obesity. One element, but that does bring to mind one other element we should include in the discussion of international comparisons, which is that in the United States, we tend to develop a lot of the medical interventions that improve lives around the world. I think, we've got a Danish company that is marketing these GLP-1s.
Wegovy.
But
Nordic, what is it? Nordic Novodisc? I forget the name of it, but yeah.
Novo Nordisk is the name of the company, but Wegovy and the other names of those GLP-1s are escaping me. Those appear to have tremendous health benefits. The United States, though, leads the world in the development of new medical innovations that don't just save lives in the United States, they save lives everywhere. The example that I usually use is Sovaldi, which is like a 95% cure for hepatitis C, developed in the United States. All the research and development spending and all the subsidies that encourage the drug companies to undertake those investments, those get counted against the United States because they're health spending here in the United States. But when that drug then improves lives in other countries get the credit for those health gains, those health improvements, even though the United States deserves a measure of the credit for that. It's one of the reasons why those international comparisons are kind of dicey. You got to be careful with those.
Yeah, there's pharmaceuticals in particular are a really strange category of product, right? Because the manufacture of them is pretty easy, relatively speaking, like relative to an iPhone. It's like once you know that this molecular...
Relative to everything that happens before manufacturing them, especially.
Right. Yeah. So once you know that this collection of molecules does this incredible thing, making those pills and putting them in bottles is just dirt cheap. But to get to that, you need to go through this very expensive, high risk, low probability process of exploring whether what is going to work and is it going to work and test if it works and go through all of that. It's and a lot of, it's very easy to talk, especially in the aftermath of COVID, to talk about big pharma and big pharma being kind of corrupt, kind of intertwined with the FDA and with federal government in a way that's like fundamentally self-dealing. My sister was actually a drug rep for AstraZeneca for a long time, and she has that view. And not that that's worth that much necessarily. It's one person's opinion, but she came to feel, a lot of people in the medical system feel like there's a lot of screw jobbery going on and a lot of just manifestly like self-dealing, not for the betterment of the patients, pushing things that aren't really that much better, but are now covered by the patents instead of out of patent and now generic. Is pharmaceuticals actually like the lowest hanging fruit to change things? Because it seems like, unlike regulating doctors and the insurance companies, and all of that, like whether or not this almost zero cost manufacture of this drug should be allowed to be much cheaper is not a matter of like the marginal cost of producing the drug. It's entirely legal. It's an entirely question of like patent law. So talk to me about pharmaceuticals. It's a big part of the thing.
That's a huge, huge area, and you're raising so many questions because they interact with public policy in a number of ways, or public policy messes with pharmaceuticals in a number of ways. The first is the patent system, which is how the government rewards the investments in research and development that you're talking about. Then there is the FDA's approval process, where you can't market a new drug or make claims about an existing drug unless you get the FDA's approval. That's an incredibly expensive process. Then you have the the FDA also regulates the manufacturing of those products. And then everything from the tax system to the Medicare program to the Medicaid program to the Veterans Health Administration and other government interventions either subsidize drug consumption or penalize non-drug consumption in a way that pumps more money into the market for prescription drugs and others. And so the net effect is that we get a lot more spending on prescription drugs than we would if the government weren't intervening at all. And the prices are a lot higher. And we also get a lot more of those innovations that I was talking about. And anytime you try to reduce the government's involvement in, say, the subsidies that it provides for prescription drugs, they will say, oh, we'll end up with less innovation if you do that. Even though the purpose of the subsidies is to innovate. If you want to more, if you're concerned about that, extend the patent life, but at least get rid of the subsidies. Because the subsidies have a lot of harmful effects. I mean, they encourage wasteful drug consumption. So we could take each one of these, but it's a whole huge issue. The way I describe the economic problem that you started with, though, is that the first pill might cost $6 billion to manufacture, because you've got to try out a bunch of theories, dig a bunch of holes that end up empty before you find that one molecule or combination of molecules that's going to have an outcome on a positive effect on an outcome of interest, or so you think. Then you've got to subject that thing to testing through the FDA's approval process, and there's actually and that can take 12 years. It can take more than 12 years. And that's where you burn a lot of the money. A lot of that $6 billion goes into finding that molecule and then establishing that it actually works, that it actually delivers the health outcome that people want. That whole process might take $6 billion, but it takes $6 billion to produce that first pill and bring that first pill to market. But to bring the second pill to market, maybe $6. And everybody wants to pay for that second pill. Nobody wants to pay for the first pill. So the economics of that are very tricky, but and the patent system is prone to all sorts of abuses where
slightly changed the formula and now it's been redone.
And now we get to extend
it's a less purple pill. Now it's got 12 more years.
Our patent life for more and more years and keep the prices higher for more and more years. So that's an incredibly complex issue. The FDA's approval, but you can come up with an economic rationale for keeping the patent system. You can't really do that with the Food and Drug Administration, and you can't really do that with all of the subsidies either, because even though there are benefits when it comes to the FDA and all of those subsidies, the harms so vastly outweigh them that we should just eliminate all of those government interventions.
So what would that look like? So this one, I feel like this one is the hardest, even like in a theoretical sense, because if it is just risky and expensive to produce that drug, it's even at the level of like, are patents good at all? I remember reading a book Against Intellectual Monopoly by an economist, Michelle Boldrin, if I remember this correctly. It's been a while, but basically the argument went something like this, and it was just empirically a case. It was an empirical review of the way patents get used, and are they this great tool that you need for innovation? And what I found generally was they aren't. That across industries over time, patent protection was not something that had an impact on whether inventors, entrepreneurs, the next Thomas Edison did something awesome. In fact, they were often doing that in spite of the fact that there was the current big player that had the patent, that patents were really just to protect the big guys that already found the thing and kind of make it so you can't compete with them. One particular example is Bill Gates, of all people, had said that if there was copyright applied to computer code in the early days of computing, with the homebrew computer club, when like Steve Wozniak was making the Apple I and like on like a little board in a wooden box, and they were all exchanging things, and open source, early versions of open source is happening. If copyright was applicable to computer code, the entire software technology industry never would have happened. But pharmaceuticals, I found, even in this theoretical literature and empirical literature, has been the singular exception because of this dynamic, because of the instant near zero cost to replicate your discovery and to also figure out what it is, because I just go to the store and buy your pill and just see what it is, and then I start making it for myself. So is there if we were in a blank slate world and we're looking at over theory and practice, is there like a different way to rig the rules that would just be better than what we have?
That your assessment is consistent with what I've read in the literature, which suggests that intellectual property protection is net harmful unless there are extremely high fixed costs and very low marginal costs. And so if the ratio of the fixed cost to the marginal cost is high enough, then patent protection might make sense. And pharmaceuticals are the paradigmatic example of that. You're not going to get higher ratio of fixed to marginal cost than you are there, probably. And in software development, that ratio is much, much smaller. So that doesn't mean that patents are the right way to go. Because there are still, this is a government program. There are going to be abuses. Evergreening is going to happen in any patent system. Patent trolls are going to happen, and patents are going to distort where you invest your research activities toward patentable innovations versus non-patentable innovations, because all patent systems have to draw lines. So. The current patent system in the United States has been subject to so many abuses that several years ago, the Cato Institute published a book by two Cato adjunct scholars, two professors of law, one of whom is also a doctor, where they detailed so many abuses and then said, look, we're not saying that alternative systems are definitely better, but we've reached a point in our patent system where the big pharmaceutical companies are using patents to their advantage and to the detriment of patients so often and so egregiously that we should look for something else. And what they advocated Congress experiment with is an idea actually that Bernie Sanders has introduced into legislation. So you had a Cato book endorsing an idea that Bernie Sanders has introduced in Congress, which is to reward the innovators not with the market exclusivity that patents provide, but with prizes, where the government, instead of saying, we're going to block anyone else from competing with you for a period of 10, 20 years, whatever, instead of saying that, we're just going to, in order to compensate you for your investment in R&D, we are instead going to give you a big fat check to say thank you for coming up with this wonderful innovation. Because then you give someone a check to reward them for that investment, then anyone can make the pill for $6, $5, whatever. The price instantly goes down to marginal cost. Now,
that's a really good idea. Thanks, Bernie.
It is.
I generally don't agree with Bernie.
We're all Bernie bros now. There are problems with that system as well, and you can probably guess what they are. How do they decide what to reward? Who gets to decide? How do they decide how big the check is going to be? There's going to be a lot of lobbying around that, and a lot of mispricing of research and development, because that's really what all of these attempts to correct the market failure of the public goods nature of knowledge generation are doing. They're trying to get the prices right. The patent system pretty clearly gets them wrong a lot of the time. And these innovation checks would also get them wrong because government doesn't know how to set prices. And so there will be errors and abuses there. The question is not, will there be errors and abuses? The question is, will there be more or fewer errors and abuses than in our current patent system? And my colleague said, maybe we should run an experiment. We should try it out and see if it works better, if people like it more.
One of the things I've always found because I've been a geek about this for a long time, just out of interest and out of family interest. One of the things I found to be like understandable, but an understandable, I think, misunderstanding about American healthcare is that the fundamental problem is those greedy insurance companies.
Mm-hmm.
Now, I think it's completely reasonable to experience what we experience with health insurance companies in America and feel that way when you have coverage, or you think you do, and then you encounter, even with all this regulation, you encounter something that the insurance company says, we're not going to cover that. Or you really have something difficult to treat, and there's a new treatment that's very promising, or it's already available in Europe and not here, or whatever, even if an American invented it, and be denied. And that experience is so widely felt in the US, or it's widely enough felt given social media and the way it magnifies particular voices, that Luigi Mangione's assassination of the United Healthcare CEO, or regional CEO, or whatever he was, turned him into a hero, turned him into like a heartthrob, gave him, I think, did Rolling Stone give him like the Loverboy cover, like they have other mass murderers? I'm not sure. But basically, Luigi Mangione is like a heartthrob among a non-trivial amount of Americans, because they feel that basically he was doing vigilante justice for like someone who had blood on their hands in health insurance. Why is that in a world where health insurance profit margins are like lower than the production of Clorox bleach?
So the episode of Brian Thompson's murder, and that's the United Health executive, and the public response to that murder were so just repulsive to me, especially because he had two teenage sons who saw their father murdered, maybe even literally saw it, and then had to listen to, millions, I don't know if it was millions, but lots of people express glee and tell them that their father was an evil person who deserved it. So just compounding their trauma was so repugnant to me that I had a hard time even writing anything at all about it. But what I decided to write was an open letter to his sons, where I tried to explain to them the following, that they can be proud about what their father did, because health insurance, voluntary health insurance, is an absolute marvel. It is such a wonderful innovation, because if you think about it, what does health insurance do? It gets a lot of complete strangers to put all of their money into a pool to pay the medical bills of other complete strangers, people they've never met. They may speak different languages, practice different religions. They may hate them if they ever met in person. But what voluntary health insurance does is it gets them to pay the medical bills of complete strangers. And if they do it only because the executives want the money and because the members of the pool, they don't want to help other people. They want protection if they get sick. If the only reason people are participating is because they're greedy, then health insurance is even more marvelous, because it harnesses all that greed and produces an unquestionably compassionate outcome, which is helping sick people through, the most traumatic moments of their lives and helping heal them and make them better. And to the extent that United Healthcare was doing that, and they did that a lot, this was a wonderful innovation that we should be celebrating. Now, that doesn't mean that the people who are upset with United Healthcare didn't have reason to be upset. I thought that they made lots of mistakes, but most of the things that people hate about private health insurance are things that the government puts unrelenting pressure on those insurance companies to do. So, for example, if you have an employer-sponsored plan,
which most people do,
and then you lose it when you lose your job, and instead of having an insured condition, you now have an uninsured pre-existing condition. Did the insurance company want to drop you, or did they want to sell you a plan that automatically dropped you when you changed jobs? They would have loved to sell plans to people that were lifelong, so they could keep collecting premiums from everybody for the rest of their lives. But the government told us the workers that will penalize you if you buy that type of health insurance plan. And so workers don't. And so insurance companies are just conforming to the government distorted demand of workers. That's not really the fault of insurance companies. What about when and along the way, that gave the insurance companies more control over your health decisions than they would have had otherwise. Remember when I said if the employer gave you $27,000 and you bought a plan on your own, you'd buy less insurance? That means the insurance company would have less influence, but because of the tax penalties on doing that, the insurance companies have more influence. So every time someone in an employer plan is frustrated with their insurance company, there's a good chance that it was the government that gave the insurance company the additional control to make that decision. What about Obamacare? Obamacare creates incentives for insurance companies to make their plans worse for the sick. There's a former economic advisor to President Joe Biden that did research on this, comparing them to employer plans, finding that insurers in the Obamacare plans use prior authorization more. They have more restrictive drug coverage for a lot of illnesses. They use step therapy more often, making it harder for people with expensive illnesses to get the drugs that they want. They use more cost sharing and more opaque cost sharing than employer plans do, all because Obamacare creates incentives for insurance companies to make their plans worse for the sick on these dimensions. But the people who are experiencing that restrictive coverage, they don't know that those incentives are coming from Obamacare. They blame insurance companies, but really the government is the problem. And we would have a lot less friction with insurance companies. A lot fewer people would be left without pre-existing, without coverage for expensive conditions. A lot fewer people would have to get an insurance company's permission to get the care that they need, and they get a lot fewer denials if the government had not been doing all of these things. So most of the reasons that people are upset with insurance companies, and most of the reasons that they were celebrating the murder of an innocent man, was because the government had intervened in health insurance markets in so many ways to make health insurance worse, and they just don't know it. And so that's what that open letter to his sons, I wrote that to explain, look, this is, you can be proud of the work that your father did. The company wasn't perfect, but the reasons that people hate private health insurance are mostly bad policy decisions that the government has made.
I think one of the most, I don't want to say surprising, but it was kind of surprising things to see in the result of this, because is in the aftermath of this. And I saw this myself in the comments on the videos I made about the issue at the time here on Dad Saves America, which has I'd say broadly right of center audience, because I'm right of center, is there was bipartisan sort of schadenfreude at a minimum about this, or at least I'm not saying he should have killed the guy, but I understand type of comments. Ben Shapiro excoriated this celebration and saw his audience get massive pushback on him. So I think the level of disgust, the level of dissatisfaction, the level of either direct or indirect stories of people who had a horrible experience at a time when almost by definition you're vulnerable, which is to say when there's anything health related, is very broad-based in such a way that arguments about the role of government versus private actors seem to become impossible to hear, because it just is I don't know what you're, all I know is my mother is dead because the effing insurance company denied this thing that was working. And then we had to stop it, and we had to shift to some generic that didn't work, and now I've lost my mother, so good riddance. And I think I think those of us, we are very like-minded on this stuff. I think how do you confront that? This is your work 24/7, is trying to make this healthcare system work better for people by getting all of this corrupt government, essentially economic fascism, out of American healthcare. It is definitionally fascist, what we have. It is the melding of the big state and big corporations in this sort of national body blob of self-interest. how have you changed, or what are you grappling with as someone trying to make the case for a more private system, when the whole thing's been rigged to make it look like the problem is always greed with these 2% profit margin companies, or because you can point to things they do, like deny services that are going to be inevitable. Like in the perfect world of health insurance, and I know I'm monologuing for a minute, but in the perfect world of a perfect market, zero government, where there's a lot less administrative bureaucracy trying to adhere to these codes to get reimbursed, because of Medicare set up this cockamamie code system that's completely idiotic, that the entire system orients around Medicare codes to try to get reimbursed. There's all this stuff that we can't even have time to talk about that's completely crazy, all constructed by the government. That all goes away, and it's a lot more like buying homeowners insurance or car insurance, where it's like, oh, rare unforeseen events get covered. And most of the time I'm spending money out of pocket, and it feels like, again, to use the car analogy, like when I go to get an oil change and it's $57 and it's basically the same price all around because they're all competing with each other and there's not that much profit in it because competition drives it out. Instead, it's like, so there would still be moments where this group of us, tens of thousands, hundreds of thousands, that put in our money into this pool for this rare unforeseen event that insurance covers, we would technically collectively want the people managing our money, because it's not their money, it's our money. We put it into the pool. It's technically our money we contributed. I don't want them to overspend on some crazy new thing that isn't going to work on you. Like, that's my money. Like, you want some crazy thing? They should tell you no. You can pay for it out of pocket. You can't use my money for your crazy idea. But then you're going to hate the insurance company, even though I think they're doing the right thing. And the reality is, I'm not going to even think that, because insurance is a kind of private socialism where I don't know that you are requesting some crazy medical intervention that your brother-in-law claims is going to cure you, and the insurance company is like, there's no evidence for that. I can't, in good conscience, cover your crazy idea from your brother-in-law. But I don't know that. You're pissed off. And even in some perfect free market world, we're in this problem. Now, I know, I'll bracket, end of monologue. Ken Arrow had stuff to talk about this, asymmetries, all of this stuff.
I'm just thrilled that I brought you from being anti-death panel to now pro-death panel, because you just made a pro-death panel argument right there. I don't want my insurance company or my dollars paying for this crazy stuff. That's like a death penalty decision you're making right there.
Oh, well, it's inevitable. It's inevitable.
It is inevitable. So here's how you raised a lot of issues. Let me see if I can address a bunch of them briefly by saying that it all comes back to the system is going to serve whoever controls the money, and and this is why we want consumers to control 100% of the health spending, because they will impose greater discipline on insurance companies than the government does, because the government, when it controls 84% of the health spending, who ends up exerting disproportionate influence over how it controls that money? The insurance companies. It's like the fox guarding the hen house. But if consumers are the ones controlling that $5-6 trillion of health spending every year, they are going to discipline insurance companies by saying, no, that insurance company denied care to my mother in violation of the terms of the contract we agreed to. And so I'm going to go to the press. I'm going to leave this
Consumer
plan.
Reports is going to rate them all.
People are going to abandon that insurance company, and insurers are going to live in fear of that sort of thing happening because they're going to lose market share. And at the same time, there are going to be people with different preferences about what insurance should cover and what it should not cover. And they will sort themselves into different health insurance plans, at least implicitly and maybe even explicitly, on based on how much for example, on how much the insurance plan says it will spend in order to buy you another year of life. That's what the National Institutes for Clinical Excellence in the UK does. That's their death panel. They say we're not going to spend more than $30,000 per year or to buy you an additional year of life. If that's how much it costs to get you an additional year of life, then yeah, we'll do that. But if it's 40, because we could save 2 lives with $40,000 over here or something like that. And if you want the $30,000 quality threshold, as we call it, quality adjusted life year threshold plan, great, you can enroll in that plan. But if I want to enroll in the $40,000 quality threshold plan, where they will spend more money on crazy newfangled stuff to try to save my life, then I can enroll in that plan. My premiums will be higher. Yours will be lower. You won't have to pay for my crazy newfangled medical treatments. And we can live in peace because I'm not trying to take anything from you. What's happening with government-run healthcare programs right now, and even with private employer-sponsored insurance, because that's a compulsory government program, basically, is that you are having to subsidize me, even though you don't want to pay for that sort of plan. And maybe you know that most of those treatments are nonsense. They're way out at what we call the flat of the curve, where we're not getting additional medical care.
Yeah.
You don't want to pay for that. You want to pay only for effective medical care. So, and yet the government forces you to pay for lots and lots of useless medical care that is as likely to harm people as it is to help them. And it's only when we let the consumer control all of the money in the health sector and make these decisions about what health plans are going to cover and what they're not going to cover, that we're going to learn what works and what doesn't. We're going to get a better match of insurance coverage to individual preferences. And I think that has a lot of intuitive appeal to people. And it's why you hear President Trump out there saying right now, we're going to fund the patient. We're going to give the money to the patient. I think with regard to employer-sponsored insurance and with regard to the Medicare program, that is absolutely what we should be doing. Take all of the money involved, give it directly to the worker or to the Medicare enrollee, and they will spend it much better than their employer or the Medicare program is spending it on their behalf. In Obamacare, maybe don't do that so much for some complex reasons that I could get into. But if we deregulate health insurance, people in Obamacare won't need subsidies. The vast majority won't need subsidies to afford health insurance anymore.
One of the things that seems to have happened that the kind of competition you're talking about seems would almost certainly would eliminate is truly wasteful consumption. We start our conversation about with the consumption of medical services that don't actually improve things. But at the time of the passage of Obamacare, I remember NPR, I've done a video about this, drawing on some of the material. NPR, of all places, it was the Planet Money team, which actually was like the sane quadrant of NPR. They've probably all been put out to pasture by now, by the Cylon that runs it, Catherine Marr. But they had this story about breast pumps. And the whole story went something like this. Under the newly passed Affordable Care Act, there was this set of required benefits. I'm forgetting the exact term for this, but it was this basically like, here's all the things that every health insurance in the country must cover.
Essential health benefits.
Essential health benefits. One of which, and among them was coverage for breast pumps, as well as coverage for pregnancy. And the story was there was a mad rush for breast pumps, including people that already had a breast pump. But hey, my insurance is now covering it for free, so why not get another one in case my one gets clogged and breaks, and it's good to have one, and maybe I can keep it at my second house or whatever. And it's pretty clear that if people are buying more goods and services out of the pool, that the premiums are going to go up that everyone pays because nothing's free. There's no such thing as free. This is like a lie that is obvious to people that live in reality and not to academics and communists. Nothing's free. But there's this other piece of the that is a kind of version of like what I'll call like Ponderosa healthcare, you know, the buffet healthcare. Hey, it's an open buffet. I'll get 2 steaks. I'll load my plate up with everything in the world. And I go and I eat and I'm stuffed a third of the way through my plate. It was $12.99. We got Ponderosa healthcare with all these mandates. How much of like the increase, how much of all of the cost is being driven by that? Because it's weird. It's weird when you get a medical bill and it's like, how is this $100,000? Like the surgery was 8 hours. It's $100,000? Like, how does that math work out? Like, is the doctor making $10,000 an hour? Like, what's happening here?
So, again, a lot of issues. So, the issue of hospital pricing is a fascinating one. What they generally try to do is set a very high list price and then negotiate as small a discount as they have to with each payer through, as we discussed earlier, an opaque process. And there are so many things that the government does to make the patient not care about the price and to reduce competition among hospitals. So some hospitals are effectively monopolists, that even though hospitals were measuring the input cost of, say, a knee replacement and seeing that it costs only like $10,000 all in, anesthesiologists, hospital fees, everything, nurses' time, surgeons' time, only about $10,000 for one knee replacement. You had hospitals like in California charging $60,000, and the insurance companies couldn't get the prices down. They just couldn't because these hospitals were basically monopolists. And, you know, if you could charge all the people who pay you 6 times what you're currently charging and they couldn't stop paying you, why wouldn't you charge them that? So I don't really blame the hospitals for that. What I blame are the policies that reduce the price sensitivity of the consumers and the ability of competitors to enter the market to bring those prices down. And that's how you end up with those $100,000 bills.
What about Ponderosa healthcare? What about overconsumption?
So yeah, that's
same thing as we talked about earlier?
Yeah, that's the same thing we were talking about earlier. Whether it's the tax code and how it encourages employer-sponsored insurance and more comprehensive insurance that people would get anyway, or the Medicare program, which they modeled on employer-sponsored insurance and also creates lots of moral hazard, or the Medicaid program or whatever. When other people are footing the bill, people want more and more health care, and they consume so much more that, you know, the best research suggests that 1/3 of Medicare spending, 1/3 of that $1 trillion, doesn't do anything to make patients healthier or happier. It encourages building new hospitals and practice patterns that are so intensive that we get results like in the Oregon health insurance experiment and in the Rand health insurance experiment. Then when you give people a quarter more medical care than the control group, it doesn't improve their health outcomes in any discernible way. And it's because when it's free, you're going to consume more and more and more and more and more, even if that additional slice of pizza isn't going to make you happy, or maybe it will. It couldn't really hurt. And that is a recipe for just wasting 5% of GDP or more on healthcare that doesn't provide anyone any benefit.
As we start to wrap up, we face, though slightly less than many other countries, but still very much a below replacement rate for level of fertility in the United States. And we have a federal debt that is so large, at I think 37 or 38 trillion, that the interest payments on the debt in 2025 exceeded national defense, if I'm remembering correctly, or very close to it. Around $1 trillion. And health care expenses, the actual care being provided, are always going to be clustered at the end of life. Because as you get old, you get sick, stuff starts to break. Before we started rolling, we were talking about like having to do this. Like feeling the fact that my knees are going to be a little like rough after 3 hours of sitting in the same position. But, that's where all the cost is. All the cost is as you approach end of life.
Not all, but it
or
ramps up.
A
It
lot.
ramps
It
up.
ramps up substantially, right? It's some substantial. I mean, it's a lot. Obviously, there's childhood leukemia, and there's all kinds of things that are like horrible and beyond behavior. And it's like that's what you want insurance for: is your kid is born and has leukemia. But that seems like a recipe for total disaster. So we have a rising aging population that's going to need more and more healthcare services, and a shrinking tax base, and an already overstretched federal budget in which the pension system called Social Security is already zero. It's already borrowing for every marginal dollar. Like it sends out more checks than it takes in revenue. And there is no trust fund. That's a scam lie, completely dishonest. It's filled with essentially the federal government's equivalent of unused bank checks against your credit card. IOUs that haven't been given out yet. So it's like, the bank sends you this check. It's not a check. It's like potential debt. That's the Social Security Trust Fund. So it's zero. It's got nothing. What the hell's going to happen? Like, what are the scenarios in your mind as a policy wonk that's been working in this area for a long, long time, when the Ponzi scheme that has enabled all this wasteful overconsumption in the United States, where we eat too much and we consume too much healthcare, most of it's a waste because, hey, I'm not paying, so I'll get two, or I'm not paying because I'm not insured and I go to the ER and it costs a fortune and then I just don't pay the bill and that gets spread out among all the rest of the patients, or I'm an illegal immigrant and I don't go. I have a buddy who's here illegally. His healthcare, he goes to the hospital, he pays nothing. He pays nothing. There's some legitimate reason to be upset about that. He pays nothing. It's like, I pay $10,000, you pay nothing because you're not here illegally? What's going on? Are we just completely effed? Is it going to require us to actually start to force constraints on things that we can just afford to kick the can on? What margin do you think is going to buckle when reality happens? Because it's going to be probably multiple places where it's going to be the pain will start to happen. But where do you think, make a prediction, even though you don't want to, I'm sure you don't want to, make a prediction where the pain starts to be impacted, where it's oh yeah, we don't have the money. We had a failed treasury auction. What are we going to do now?
First of all, a couple clarifying things. One is that the population of workers is not shrinking, but it is growing more slowly, much like Medicaid. It's not a cut, but it is growing more slowly. It's not growing as rapidly as the seniors or their medical expenses, and that's a real big problem that you correctly identify. Also, kind of good news and bad news on the debt before I get to the really part of the bad news on the federal debt. You're right, the trust fund is not a trust fund. There's no assets in there. It really is an institutionalized, ritualized lie that the federal government tells to the people that we have this trust fund that's paying for your benefits. We don't.
Yes.
It's a fiction. Their IOUs, the government writes to itself. Now, the good part of that bad news is that means that the federal debt is not as large as you say it is.
Right.
Because
the intergovernmental debt you can just basically remove.
About $7 billion of that $37 billion is phony.
Yeah.
$1 trillion. Yeah. Thank you. $1 trillion. It's phony debt, just like the trust fund is phony assets. So let's take all that out and throw it out. So we're left with merely $30 trillion of federal debt. 100 equal to the size of the entire U.S. economy. The debt to GDP ratio is 100%, and we're adding another 6% to it every year.
Which is more than double the the growth rate. So that is an accelerating problem.
Growing faster than GDP, and the reason that the federal debt is growing is because of healthcare. Interest payments on the debt might be bigger than national defense at this point, but it's not bigger than federal health spending, which is the largest category of programmatic federal spending and the only one that is growing faster than GDP. The only other category of federal spending that's growing faster than GDP is net interest, and net interest is largely because of healthcare. So now here comes a really bad part of the bad news, which is what's going to give. Stein's law says if something cannot go on forever, it will stop. And Congress cannot keep borrowing at the rate that it is borrowing, because at some point the bond markets are going to say, we're not sure you're going to pay us back. You might even want to pay us back, but we're not sure that you're going to be able to pay us back. And at that point, you might have a bad Treasury auction, as you say, and Congress is not going to be able to come up with the money to keep spending the way that it is spending. And so at that point, Congress is going to try to do other things to try to keep all the spending going and save us from economic catastrophe. It might try to raise taxes. It's going to have a hard time doing that. Before that, it'll probably try inflating all of its obligations away, printing more money, devaluing the currency, but they'll have more money on hand so that they'll be able to pay Social Security and Medicare.
Yeah, that's the
bills.
quiet default option. Like, oh, we're not going to default. We're just going to give you less valuable money in return because your debts are dollar denominated.
Right. It's a hidden tax on everyone who holds dollars.
But there's a limit to that, because we already saw in 2022, the public doesn't like when eggs go to $12.
Right.
It's like, no, what are you doing?
And so whether they try to raise taxes and anger the public that way, or devalue the currency and anger the public that way, eventually they're going to hit a budget constraint. And when they hit that budget constraint and the public says, cut spending, where are they going to go first? They're going to have to go to healthcare. Why? Because as Willie Sutton said of banks, that's where the money is. As I said, largest category of federal spending.
We already killed foreign aid, thank God. So this is the favorite thing to we killed foreign aid and NPR PBS. So the favorite go-tos are not on the table.
And they should cut health spending because of all that waste that we've mentioned. So that's good. But the really heartbreaking, inequitable part is that the first place they're going to go is Medicaid. They're going to cut Medicaid first for a number of reasons. The first reason is that
poor people don't vote that much.
Poor people don't vote like seniors do. Yeah. Medicaid is a poor program because it's for the poor, or the adage goes. And when Congress needed to come up with some savings in order to pay for the tax cuts in the One Big Beautiful Bill Act, they went to Medicaid, not Medicare. President Trump said Medicare's off the table. The second, and that's the reason they did it. The second reason that they're going to go to Medicaid first is because it's growing faster than Medicare. The third reason is because they'll be able to pass off for responsibility for what happens onto states. They'll be able to say to states plausibly, hey, if there are problems, you come up with the money. We're done deficit spending. We don't want to raise taxes any more than we have to. So if you want to spend money on Medicaid, you raise the taxes. And so for all those reasons, they're going to be throwing off of the Medicaid program, ending federal Medicaid healthcare subsidies to the most vulnerable people who are receiving federal assistance. That means that every time a state expands the Medicaid program, they're putting their low-income residents in a very precarious situation, like we've already done in the 40 states that have implemented Obamacare's Medicaid expansion, because when Congress hits that wall, they're going to be the first ones to go. They're going to be the first ones to lose their subsidies. Not the last ones, but the first ones, because we didn't look for approaches to health care and health insurance that were more sustainable, that aren't where the bottom isn't going to fall out. If we do what I proposed earlier, which is allow people from Texas to buy insurance from U.S. territories more affordably than under Obamacare, they don't have to worry about Congress slashing their Obamacare subsidies and losing their health insurance. They will have secure lifelong health insurance that's not subject to Congress's budget decisions. So the next people they hit might be Obamacare, but they're even going to have to come after Medicare recipients, because that's the largest of the largest. Healthcare is the largest category of federal spending, and Medicare is the largest single item in that category. And so, all told, you've got 120 million people in the United States who are relying on some form of government subsidy in order to access healthcare, and it's all going to be on the table if and when Congress hits a budget constraint. And that's there's got to be better ways to do this, and there are. It begins with what I mentioned before. let the workers control the money their employers are controlling, give the seniors and others in Medicare cash rather than the Medicare coverage they're getting now, because they'll start spending that money more wisely and prices will plummet, making healthcare more universal and affordable for more people, and also showing that we don't need to spend as much money on Medicare as we're spending right now to deliver the same outcomes. We don't need to subsidize as many people in Medicaid as we are right now, because more people will be able to afford care themselves at much lower prices.
There's this assumption that the costs of healthcare go up faster than inflation, like just because or something. Whereas like every other advanced technology-centric goods and services industry, the prices actually go down, or even if the prices stay the same, like year over year. Like the iPhone is actually an example of getting better, and even when the price stays the same nominally, over the past 5 years with the inflation, it stayed nominal while the rest of prices went up. So, and the reason is because you get more efficient, right? You figure out how to do more with less. That's what profit maximizing firms try to do. How can we do more with less, given that that's the only way we're going to keep our customers in a world with competition? We have to figure out how to get better, how to do more with less. Oh, wait, this new pill is better than this former horrendous long-term drip treatment. Great, let's switch to the pill. That is a bottom-up, decentralized market process of competition and trucking and bartering and shopping for services and whatnot. How likely do you think it is that what will happen when this inevitable bust occurs? And this bust could occur in our lifetime, or we could kick the can because we're the tallest pygmy and our debt sucks except for all the other countries on earth. What about the call towards let's just grab all the money. Let's just have Medicare for all. Let's, if not ban private insurance, functionally take it over and see the sum total of all spending as being stuff for Uncle Sam to take control over. Do you think that's what's your over under on Bernie Sanders winning the day in the crisis moment?
Oh gosh. Well, I'd put the likelihood of that at 5%.
Really? That low?
Yes.
Why?
Because Medicare-For-All really is a pipe dream. I mean, even on the left in health policy circles, there's so much skepticism about Medicare-For-All because, as you remember Donna Shalala, she was Secretary of Health and Human Services under President Clinton, so she ran the Medicare program, and then she was a congresswoman and a university president. She said that most of the people she knows, she said she's never met a person who supports Medicare for all who actually understands how the Medicare program works. The Medicare program does not make healthcare more efficient. It makes healthcare less efficient. It sets prices too high all the time. Democrats don't like admitting that, but they know it, and that's why they passed in the Inflation Reduction Act provisions to try to reduce Medicare prices for prescription drugs. But Medicare prices overpay for hospital services, and they overpay for physician services, all sorts of things all the time. And that is why, one of the reasons why, as I mentioned earlier, Medicare makes us more of an outlier in terms of health spending among wealthy nations. So the idea that when there's a crisis, we can just move everyone into Medicare for all, just doing that by itself is not going to save money, because doing that would and saving money would require reducing the prices that providers receive for treating all of the people that you're moving into Medicare, and they are going to scream bloody murder. And there will be pressure to cut. But I think it is more likely that that people will demand that Congress give them some degree of control over how those cuts fall upon them, and that Congress will want a little more certainty about how about total Medicare expenditures. And the one reform that does both of those things is giving seniors cash like Social Security does, giving Medicare enrollees cash like Social Security does, because then you can at least say, hey, we're going to spend this much on Medicare over the next 10 years and just divvy up how much we spend among all the enrollees by giving them each their share of that total. You can give them cash, which allows them to choose which medical services are most important to them. So you're protecting them from the rationing that's going to be coming, allowing them to protect themselves. But also you're giving Congress a little more certainty about the spending trajectory of Medicare, because if you just keep the Medicare program as it is right now, the industry is going to game it the way they have for the past 6 decades, and you're going to keep Medicare spending on a higher growth path. And if you want to, get your bond rating down, and if you want to please the taxpayers who are really mad at how much you're trying to raise their taxes, you're going to need to constrain Medicare spending growth in a way that I think only that approach allows.
At the most basic level, there is this roll of the dice that in health that I think we all experience, and in different ways. Some of us will go our whole lives and never have something that's like, what the hell happened? This came out of nowhere. I got this weird thing. But there is a randomness. There's an asymmetry to it. We can have genetic diseases that we didn't choose. It wasn't a lifestyle choice. Stuff happens. And I think for that reason, there's been a kind of, there's like a basic intuition that that feels like just leaving health insurance and healthcare to a perfectly free market with nothing that protects the kind of like random unlucky soul that's born with something horrible, some congenital condition, the various cancers, all this stuff that hits all of us. Well, some of us technically, but Kenneth Arrow, the economist, has written about this, about these things that are sort of baked into there's almost nothing we wouldn't pay to stay alive in the face of a disease that we got through no fault of ours. Like if tomorrow I woke up and I had some horrible disease, I would do everything I could to stay alive.
No, you wouldn't impoverish your children.
I know, I wouldn't do that. I wouldn't.
So there
do
is
that.
a limit.
There is a limit, but there's a sense of there's an extremity to the worst case scenario of a health problem. Do you think that a middle ground approach could be something like converting all of this crazy government healthcare spending? I realize this is all utopian because it's far too clean and logical for the government to actually do because of politics. But let's imagine we had a rational dictator for a short window of time, a kind of Pinochet without the dropping people out of helicopters. We got the best version of a dictator you could possibly have for just a minute. And he's like, all right, I got the solution. We're going to convert all this federal government stuff into a universal, from birth till death, catastrophic coverage deal. And we're going to somehow set the deductible would need to be much higher than anything we currently have. This would be a backstop, but it would be universal for everyone.
Maybe it's percentage of income.
Yeah,
there you go.
Yeah, something like percentage of income. I don't know. I'd have to think what are the marginal impacts on that? But it's something like, okay, it doesn't create disincentives to work. Or not in some way that's like a cliff. And then the rest is up to you people. If you're born with leukemia, you're never going to spend more than X. You come down with Parkinson's. We got you up to that, once you hit the threshold, and the rest is up to the private market, and all of you guys have to sort it out. Would that be an improvement? Is there anybody that's even remotely close to that on planet Earth?
I don't think so. On day one, relative to what we have right now, on day one, that might be an improvement. But I have questions about day two.
Okay, go on.
On day two, my questions about day two are like this. Is this dictator? Is he going to be around on day two? Is he going to be around forever? Is he going to die ever?
No, he's the perfect dictator. He comes in, there's this thing, he rewrites the rules, and then he's out of here and he's like, hey, it's a new republic if you can keep it, and he flies off into
And then
the
he
sunset.
flies off. Okay, who governs the rules after that? Who decides
It's the same old democracy republic nonsense.
Oh, okay. Well, then on day two is when that starts to come apart. And people start lobbying to reduce the deductibles in that plan and have it cover more stuff because the healthcare industry has the biggest incentive to lobby on those questions, and they want more subsidies from the government. They want more subsidies in the form of the government starts paying sooner and paying for more stuff, and they want to increase the prices the government pays, lather, rinse, repeat. In a few years, we're right back where we are.
Yeah, that's the thing. Public choice.
90% of the profession of economics is just asking the question, and then what happens?
Would there be? I guess, yeah. No, that's true. One can dream, can't you? As we, what are causes for optimism? Let's end on a positive note. Where is there the best signs that there's? Is it like GLP-1s and bringing down the collective weight of the American public, both physically and fiscally? Is there AI bringing down the price of pharmaceuticals? What do you think is the cause for something less than apocalyptics?
You have said, many have said, that wouldn't it be great if healthcare worked like other markets, where prices went down at the same time quality improves? Because innovation on the cost side, as well as the quantity side, just made our lives better all the time. Yeah. And the good news is that markets are trying to do that all the time. Innovators are trying to do that all the time. Reducing the cost of basic primary care and prescription drugs and hospitalizations and improving the quality of these things over time. I mean, in real time, we have seen prices for things like hip and knee replacements fall by 25% over a 2-year period just by making the consumer more price sensitive, pulling that market mechanism into the picture. And all of a sudden, these prices plummet, stuff becomes lower priced, more affordable, and therefore more abundant, and people have more resources to spend on other needs. Okay, this sort of thing happens in all aspects of healthcare and health insurance all the time. We've seen tremendous innovations in health insurance, where insurance companies, just to please their consumers, make their health insurance products better and more secure, so that people who develop expensive illnesses have secure access to care for longer periods of time than they do in employer-sponsored plans or in Obamacare plans. But why aren't we seeing those innovations? Why aren't those innovations making healthcare more universal? And the reason is they run up against government barriers all the time. They run up against state clinician licensing rules that say, no, you can't experiment in that way. You can't make healthcare more affordable in that way. They run up against insurance regulations that say, nope, you can't offer affordable health insurance to people. We're not going to let you do it. We have better designs in mind. So they say.
Yeah, we have minimum viable, mandatory, high expense. It's like you can have a car. You're only allowed to buy a C-class Mercedes or above.
You want to sell people lifelong health insurance. You know what? You can try to do that. Well, actually, we already prohibited it. But even if we weren't prohibiting that health insurance, we would penalize workers if they signed up for that plan. So we're not going to let that happen. And then instead of letting the market do what it does and make stuff more abundant and bring healthcare within the reach of even the most vulnerable people among us, we're going to subsidize the heck out of healthcare with these massive entitlement programs that are going to drive up prices and reduce the quality of care. The Medicare and Medicaid programs have not just flooded the market with subsidies that increase consumption and increase prices. They've actually reduced the quality of healthcare goods and services, leading people to have worse health outcomes as a result of all the subsidies and purchasing rules in these programs. So the cause for optimism is that better health care is waiting for us if we only get rid of all of these government interventions that are standing in the way of lower cost, higher quality health care.
Who has the best healthcare system in the world? Even if we can't import it because it's different people, different politics, and
Right.
just who's the best? Who's the best in the world?
So I don't know the answer to that question. Different countries are better on different dimensions. Like in the United States, I think we get more innovation, not only in new treatments, but also in new insurance products. Until 2014 and Obamacare outlawed that innovation. Right now, I think that Germany is leading on health insurance innovation because those products that I described that provide long-term access to care for people who become ill and let them continue to pay healthy person premiums, that's still a viable market in Germany. They allow that there to coexist alongside the compulsory government plan. Chile and Australia have markets like that are less robust. But what the economic research shows in Germany is that those insurance markets come within like 4 percentage points of what the economists would consider optimal. That's fantastic. But Germany's system has problems in other dimensions also. But in the United States, we do also see the experiments like the one I mentioned that showed how to get prices down for hip and knee replacements by 25% and how to get them down even further for those in other goods and services. The problem with the reason why we can't really answer that question is because no one has gathered the data in a systematic way that would allow us to measure which countries allow their or respect their residents' right to make their own health decisions, and which countries use markets to allocate healthcare resources more than other countries do. And until someone gathers those data in a systematic way, I can't really give an answer to that. I can only say that there are parts of the U.S. health sector and parts of other countries where market forces have been given room to breathe, and we see some pretty amazing things.
I know two last sort of data, world comparison data things before we come to an end. One is in Michael Moore's Sicko, and this has been used, I mean, this is an old movie, but it's been a talking point for a long time on the left in particular. He noted that in, I think it was like the World Health Organization's ranking of healthcare services, and as well as life expectancy, the U.S. sucks, or it's like it's nowhere near. It's not even in the top by any stretch. When I looked closer at that data, it was like, wait a second, there's all kinds of nonsense in here. The ranking itself is like a lie because the large groups actually had no statistically significant differences, but they ranked it anyway, and so we were like number 39 or something. So I imagine you're familiar with this. What's the truth about this often cited ranking of the U.S.? Just not in terms of whether it's true to reality, but in true of just like judged on its own terms, that popular rank method.
That study that purported to present a lot of health data, a lot of it wasn't about health, and a lot of it wasn't even data. So some of the data they literally made up. They just made up the numbers. Some of the numbers they didn't make up were measures of health or a country's health system, like the following: how much of health spending comes from the wealthiest in society? Do you have a tax system that where you have rising marginal tax rates or some other feature that makes the wealthy pay disproportionately more, a larger share of their incomes than low-income people do. And another measure that says, how well do they insulate people from the prices for the medical services they consume? Now, in those two measures, you may notice something, a principle, a concept you've heard of before. The first measure tries to capture how well a country's health system conforms to the principle of from each according to his ability.
Right.
And the other one...
It's ranked by how commie you are, basically.
And the other one tries to capture how well the health system adheres to the principle of to each according to his need. This is a measure of the performance of a nation's health system. This isn't about health at all. This is about ideology, specifically Marxist, literally Marxist ideology. And so serious scholars didn't really take the World Health Organization international rankings seriously.
The second piece is one thing you didn't say in this whole conversation, which I'm kind of surprised by, is that despite all of our inefficiency and our bloat, you did say we innovate. But it used to be the case that a common retort from those of us on the more free market, more conservative libertarian side was that we actually still have technically the best healthcare system in the world, actually. That we have better outcomes once you dive into the particulars. Once you look at, and I've seen recent data on this that actually seems like it still is true, that actually if you look at mortality and life expectancy, stripping out non-healthcare related stuff like dying in a car accident or gun violence, we're like top of the pack. If you look at the quality of life and the response to all the various cancers, we actually are like a leader. So are we, at least along some dimensions, even if we're still spending too much and still bloated, inefficient, and loaded with all kinds of fraud, still pretty good on some things? Are we, or have we even not really have we lost that?
So, we might be good on some health outcomes. Some people think that we're better on cancer outcomes in other countries. And this is holding innovation constant. And so put aside our innovations. But there's also suspicion that because we subsidize healthcare so much more in this country than in other countries, we end up with not better cancer outcomes, but broader diagnosis and earlier diagnosis of cancers. And so in the 5-year survival statistics, we might look better, but it's only because we captured cancers at earlier stages, including cancers that weren't going to kill anybody. And therefore, the longer survival rates did not mean that we were keeping people alive longer. It just meant that we were starting the clock earlier.
Ooh, oh, interesting.
And so I'm not really sure, but I will say this about why I don't say rah rah United States, we're better than other countries, or rather, why I think some people do say that when I don't think the data really support it. I think there might be a nationalist impulse to say that. You just want to make your country look better than others. And you're tired of all the condescension from the Europeans whose lives the American innovation is saving. I get that.
Yeah, like of the French premier, or what was it? There was like a Canadian politician who came down to the U.S. for a heart treatment. And it's like, see, the pets get better health care than the people in Canada.
Sure. We're saving their lives and they're not grateful for it. Fine, whatever. But then there's this other impulse that I think I once maybe even shared, which is that a lot of people on the free market side have accepted this premise that the United States is a free market system and therefore they have to defend it.
Right.
And I would love to disabuse them of that notion. You don't need to defend what we have right here. You don't need to say this is better than other countries because this is not more of a free market than other countries. On a lot of measures, we have less of a free market than other countries do when it comes to healthcare. And so let's put all that aside. Don't worry about that. Let's just look at what is happening in the United States versus other countries. And that's how I arrive at the answer that I gave you, which is we're better on some things like innovation and worse on other things like prices. The prices here appear to be much higher than in other countries. I should say excessive prices, because if they're higher here because of supply and demand, that's fine. But there are a lot of, or because of the underlying economic realities giving rise to supply and demand. But if I'm talking about excessive prices due to policy, and I think we really do have a problem, a unique problem among advanced nations.
I asked this of every guest. This is the first time on the show that we've known each other a long time. Probably we've met before that bizarre Ann Coulter speech moment that we talked about at the start. This show's called Dad Saves America because I really truly believe that as men, fatherhood is a central role that we can play in not just the family, but in the future of the country. That we get to play a role that is important, that is meaningful, and that matters and ripples out. How do you think about your role Sure, as a dad, as a man, but also as an American in this country's story.
So, wow, I hadn't thought about the role as a father and a citizen in the same terms before, but or in the same sentence. But I think I sort of conceive of my role and my duty in each sphere as being substantially the same, which is, I had fantastic parents, not perfect, but fantastic parents. Met so many of my needs and set me up for success in life, and really discharged their duty to me by, I think, giving me an even better life than their parents gave them. And that is my duty to my children, to be a little bit better, to give them a little bit more than my parents gave to me. And similarly, when it comes to being a citizen, I see that as my duty as well. And a citizen of this country and also of the world, to leave the world a little better than I've placed than I found it. Sort of the Boy Scout role. And I, thank you for asking me the question, because I hadn't made that connection before, but that really is sort of an ethos that I carry.
Michael Cannon, this has been a wonk fest of the best sort.
It really has. It's been fun.
Thanks for being on Dad Saves America.
You bet. Thank you.